management. And first in this series, we are starting with Dr. Vidyadhar Bedesar, who is a consultant neurophysician in the global hospital, big hospital in Nanded, and doing successful practice since 15 years. He is a leading neurophysician in Nanded. Uh, we can start with him. The topic of the discussion is migraine in general practice, often undiagnosed and misdiagnosed. Over to Dr. Bedesar.
Thank you, sir, for kind introduction. First of all, I thank IMA for giving this opportunity. So today I am supposed to speak on migraine in general practice, which is often undiagnosed and misdiagnosed. Any other members have joined?
Yes, sir. We have more than 100. Yes, sir. We have more than 115 attendees.
Okay, sir. Yes, I am starting now.
Yes, sir.
So, migraine is a common disabling primary headache disorder. Epidemiological studies have documented its high prevalence and high socioeconomic and personal impacts. In the Global Burden of Disease Survey 2010, it was ranked as the third most prevalent disorder and seventh highest specific cause of disability worldwide. Due to poor awareness of it amongst patients and physicians, it is often undiagnosed and misdiagnosed. It is investigated unnecessarily, that increases the cost of the burden. And imaging often a source of additional worry for the patient when normal variants, unrelated findings, benign cysts, and age-related changes are reported. Many of the times, even if it is diagnosed, it is undertreated with inappropriate drugs or doses for migraine and associated comorbidity that leads to treatment failure. Therefore, it is important to promote migraine awareness to reduce its burden and limit direct and indirect costs and the risk of exposure to useless investigations. The International Classification of Headache Disorders. It classifies migraine into various subtypes. These are migraine without aura, migraine with aura, chronic migraine, complications of migraine, probable migraine, and episodic syndromes that may be associated with migraine. The diagnostic criteria for migraine without aura are: A, at least 5 attacks fulfilling criteria B to D. B, headache attacks lasting 4 to 72 hours. C, headache has at least 2 of the following 4 characteristics, that is unilateral location, pulsating quality, moderate or severe pain intensity, and aggravation by or causing avoidance of routine physical activity. D, during headache, at least one of the following should be there: the nausea and or vomiting, photophobia and phonophobia. And E, it is not better accounted by other international headache disorder diagnosis. Then migraine with aura diagnostic criteria are at least 2 attacks fulfilling criteria B and C. B is 1 or more of the following fully reversible aura symptoms. There are visual, sensory, speech and or language, motor, brainstem, retinal. C, at least 2 of the following 4 characteristics. At least 1 aura symptom spread gradually over 5 minutes and or 2 or more symptoms occur in succession. Each individual aura symptom lasts 5 to 60 minutes. At least 1 aura symptom is unilateral and the aura is accompanied or followed within 60 minutes by headache. And D, it is not better accounted for other headache diagnosis. Then chronic migraine, headache occurring on 15 or more days per month for more than 3 months, which on at least 8 days per month has features of migraine headache. It is impossible to distinguish the individual episodes of headache in patients with such frequent or continuous headaches. And in fact, the characteristics of headache may change not only from day to day, but even within the same day. The migraine has various phases. The early symptoms, aura, headache, and dissolution. Early, these are also called premonitory symptoms, and postdrome is a resolution phase. Some patient migraine with aura patients may have aura. So headache is the most common complaint by the patients. If the patient comes with typical history of headache, then it becomes easy for diagnosis. But many of the times, patients present with premonitory symptoms or postdrome symptoms. These are very non-specific symptoms. patients do not give history of headache. On asking, some patients may agree that they have acidity headache since last 10 years, 15 years, but they do not complain the headache as a primary symptom. So they complain primarily the early, this premonitory symptoms and postdom symptoms, or sometimes individual only aura may come. It may not be followed by headache. So for patients, there is no headache, but in the past or previous episodes, there may be such episodes of headache which the patient has forgotten. So because of these early symptoms and postdom symptoms, sometimes it may be difficult to diagnose migraine, and patients are investigated unnecessarily by costly investigations. So it is important to know the early symptoms, aura symptoms, and postdom symptoms. The premonitory symptoms, they may begin hours or day or two before other symptoms of migraine attack and a headache resolution phase. They include various combinations of fatigue, hyperactivity, hypoactivity, depression, craving for particular foods, difficulty in concentrating, neck stiffness and or pain, sensitivity to light or sound, nausea, blurred vision, dizziness, or repetitive yawning and pallor. So if such symptoms, patients come with such symptoms, you have to ask the history of the headache in the past. You have to ask it again and again. Patients most of the time they deny that they don't have history, but they have acidity headache, but when there is change in atmosphere, they have headache. After traveling, they have headache. That is migraine. So these symptoms are associated with migraine. Then migraine aura. The aura is a complex of neurological symptoms that occur usually before the headache of migraine with aura, but it may begin after the pain phase has commenced or continue into the headache phase. The aura symptoms may be visual, sensory, speech and or language, motor, brainstem or retinal. So visual aura is the most common type of aura, occurring in over 90% of the patients with migraine with aura, at least in some attacks. It often presents as fortification spectrum, a zigzag figure near the point of fixation that may gradually spread right or left and assume a laterally convex shape with an angulated scintillating edge, leaving absolute or variable degree of relative scotoma in its wake. Next in frequency are sensory disturbances in the form of pins and needles moving slowly from point of origin and affecting a greater or smaller part of one side of the body, face and or tongue. And less frequent are the speech disturbances, usually aphasic but often hard to categorize. So sometimes what I am telling you is this aura symptoms may be present without the phase of headache. So we have to diagnose it correctly. Then migraine aura versus TIA. Sometimes if it is not followed by headache, it may be confused. Either sensory or visual aura may be confused with transient ischemic attack. Migraine with only a visual aura but no headache may be mistaken for transient ischemic attack. And like a stroke, migraine can be sudden and can lead to mild confusion. However, migraine aura symptoms tend to develop relatively slowly and then spread and intensify, while the symptoms of TIA or stroke are sudden. Then vestibular migraine. Approximately 40% of the migraine sufferers experience significant vestibular symptoms, vertigo or balance disturbances before an attack or as the main symptom. Persistent vertigo is often misdiagnosed as vestibular disease, and people can spend a long time trying various treatments without success. So when should I suspect vestibular migraine? Vestibular migraine is often diagnosed as BPPV, benign paroxysmal positional vertigo, or acute neuronitis or labyrinthitis, which does not respond to traditional treatments. The headache symptoms are often missed, and as nausea and vomiting are common features in both of those conditions, migraine can be overlooked. If other migrainous features are present, such as sensory sensitivity to light, sound, smell, touch, and movement, cognitive changes like memory loss, slowing of thoughts or brain function, or headache, head, neck, or facial pain are present, then migraine should be suspected. A number of patients suffer vestibular migraine without headache, and vestibular migraine should be suspected if vertigo persists and any of the above features are present. Some patients migraine patients have heightened sensitivity for vasovagal syncope. The syncope affects all age groups and is characterized by brief sudden loss of consciousness followed by fast recovery. Vasovagal syncope has been documented in high proportion of patients with migraine. In approximately 20% of the cases, more than one family member is affected. Age at first episode of syncope ranges from 2 to 7 years. Age at first migraine headache is less than 10 years in most of the cases in such patients. The typical example of these patients is children, the pre-primary, primary children standing in for assembly. They suddenly fall down. So I think this is probably a precursor of migraine. Such children later on they develop typical migraine headaches. Then migraine and psychogenic non-epileptic attacks. About a quarter of patients with migraine, especially adolescents and adult females, have history of psychogenic non-epileptic seizures during attacks of acute migraine. Compared to epilepsy patients with migraine, non-epileptic seizures patient with migraine report having a more severe form of migraine with more frequent and longer duration attacks that are more commonly associated with non-visual migraine auras. So non-epileptic, so we should, if patient or the typically adolescent females present with such similar symptoms, we should ask the history of headache. Sometimes may they not complain the migraine, but they are, the main problem is their migraine headache, and this psychogenic non-epileptic attacks, they are the symptom. So if we properly control this migraine, thus non-epileptic seizures, they subside automatically. Migraine, particularly chronic migraine, as well as other chronic headaches, have high rates of comorbidity with mood and anxiety disorders. Migraine is not a psychiatric disorder, although behavioral factors can critically influence the onset and course of headache episodes. In rare cases, headache may be a symptom of psychiatric disorder. So identifying comorbid illness is essential because management of both migraine and psychiatric condition often requires separate agents to target each individually. Headaches secondary to psychiatric disorders are usually distinguished from migraine by headache occurrence only during active phases of the psychiatric condition. Most commonly, headache occurs as one of the many unexplained symptoms in a somatization disorder or as a delusion during psychosis. Sufferers are usually women in whom numerous standard therapies have failed and who obtain headache relief only after direct and successful treatment of psychiatric disorder. If migrainous headache occurs at times other than during the active phase of psychiatric illness or fails to remit when the psychiatric symptoms abate, then the migraine is appropriate diagnosis. So assessing the temporal pattern of headache in relation to psychiatric symptoms is most valuable diagnostically. So sometimes these migraine and psychiatric disorder, they may overlap. So identifying correct. So categorization of these two is important because treating correctly may correct either psychiatric disorder or migraine. If the patient, the psychiatric symptoms are because of migraine, severe migraine, so migraine should be targeted. If psychiatric disorder is prominent and migraine is the part of this psychiatric disorder, then psychiatric treatment should be targeted. Then ocular causes of headache. A literature review reveals historical references to an association between migraine headache and refractive errors, but there is a lack of scientific evidence relating to these claims. Migraine patients may have higher degrees of astigmatism, spherical refractive error, and anisometropia. There has been ongoing debate whether uncorrected refractive error causes asthenopia or eye strain. Indeed, low degrees of astigmatism and anisometropia may be relevant in migraine because migraine patients, if they need prolonged tasks, they need accommodation. If the patients have associated even minor astigmatism or anisometropias, they may have more strain for doing visual tasks. So the migraine symptoms may be precipitated early. This may be the explanation for ocular headache in refractive errors. Although there is little evidence that refractive error or strabismus directly causes headaches, appropriate correction may improve symptoms. People who experience migraine headaches should attend their ophthalmologist regularly to ensure that the refractive errors are appropriately corrected. Headache and refractive errors. are very common conditions in the general population, and those with headache often attribute their pain to visual problem. The International Headache Society criteria for the classification of headache includes an entity of headache associated with refractive errors, but indicates that its importance is widely overestimated. Refractive error is much less commonly a cause of headache than is generally believed. There is some evidence for it in children and sometimes in few cases in adults. So the criteria for headache attributed to refractive error are: headache has developed and or significantly worsened in temporal relation to the onset or worsening of refractive error. Headache has significantly improved after correction of the refractive errors. Headache is aggravated by prolonged visual tasks at an angle or distance at which vision is impaired. And headache significantly improves when the visual task is discontinued. Other cause of ocular cause of headache is the acute angle closure glaucoma. Headache usually, here the headache is usually unilateral, caused by acute angle closure glaucoma and associated with other symptoms and clinical signs of this disorder. Acute angle closure glaucoma generally causes eye and or periorbital pain, visual acuity loss, conjunctival injection, and edema, nausea, and vomiting. So it is not difficult to differentiate from the migraine. Then headache attributed to ocular inflammatory disorder. Sometimes headache is caused by ocular inflammatory conditions such as iritis, uveitis, scleritis, or conjunctivitis, and associated with other symptoms and clinical signs of this disorder. Because of the nociceptive field overlap and convergence, any ocular source of pain may lead to headache in any region. When the ocular inflammatory disease is unilateral, headache is likely to be localized and ipsilateral. Since the eye is a transparent, superficial organ and routine examination techniques readily identify these ocular causes of headache, it is not difficult, it is not to diagnose and separate it from migraine. Then headache attributed to acute rhinosinusitis. So headache caused by acute rhinosinusitis and associated with other symptoms or clinical signs of this disorder. The migraine can be mistaken for headache attributed to acute sinusitis because of similarity in location of the headache and commonly accompanying nasal autonomic symptoms in migraine. The presence or absence of purulent nasal discharge and or other features diagnostic of acute rhinosinusitis help to differentiate these conditions. Headache attributed to acute rhinosinusitis. The pain due to pathology in nasal mucosa or related structures is usually perceived as frontal or facial, but may be referred more posteriorly. Simply finding pathological changes on imaging of acute rhinosinusitis correlating with the patient's pain description is not enough to secure the diagnosis of headache attributed to acute rhinosinusitis. Headache should significantly improve or resolve in parallel with improvement in or resolution of the sinusitis. Sometimes an acute episode of migraine may be triggered or exacerbated by nasal or sinus pathology. So it is a concurrent pathology. Headache attributed to chronic or recurring rhinosinusitis. It has been questioned whether the chronic sinus pathology can produce persistent headache. Usually it is not common, but headache waxes and wanes in parallel with the degree of sinus congestion and other symptoms of chronic rhinosinusitis. So typically the sinus headache, the headache location is face, forehead, or periorbital area. Its nature is throbbing in migraine or may be preceded by aura, while in sinus headache, there is pressure behind eyes or face, dull bilateral pain, worse in the morning. Onset is sudden in migraine. It is simultaneous with sinus symptoms, including purulent nasal discharge. Duration in sinus headache is usually days and resolves with sinus symptoms with proper treatment. And non-headache symptoms are nausea, vomiting, and phonophobia in migraine, while nasal congestion, fever, purulent nasal discharge are the symptoms associated with sinus headache. Then migraine versus meniasis. Sometimes in clinical practice, patients may present with both the symptoms. So migraine may be confused with Meniere's disease, or sometimes Meniere's disease is labeled as migraine. So migraine is more common in patients with Meniere's disease than in healthy controls. Many patients with features of both Meniere's disease and vestibular migraine have been reported. There is fluctuating hearing loss, tinnitus, and oral pressure may occur in vestibular migraine, but hearing loss does not progress to profound levels as in Meniere's disease. Similarly, migraine headaches, photophobia, and even migraine auras are common during Meniere's attack. In the first year after onset of symptoms, differentiation between them may be challenging since Meniere's disease can be monosymptomatic with only vestibular symptoms in the early stages of the disease. Usually the cochlear symptoms, that is tinnitus or deafness, then appear in 1 or 2 after 1 to 2 years. So first 1 or 2 years of the Meniere's disease may be confused with migraine. Then cervicogenic headache. Again, this is also commonly confused with migraine. So headache caused by disorder of cervical spine and its component bony disc and or soft tissue elements, usually but not invariably accompanied by neck pain. The headache has developed in temporal relation to the onset of cervical disorder or appearance of the lesion. The cervical range of motion is reduced and headache is made significantly worse by provocative maneuvers, that by neck movements. And headache is abolished following diagnostic blockade of cervical structure or its nerve supply. Cervical blocks, the symptoms subside. The imaging findings in the upper cervical spine are common in patients without headache. They are suggestive but not firm evidence of causations. So many of the patients actually in practice, they have migraine, especially young patients, they have migraine, but most of the time X-ray cervical spine or MRI cervical spine is done because of associated neck muscle spasm. And some if some pathologic changes are there, they are attributed to the cause of headache, but actually it is migraine. And these associated imaging findings, they are the incidental finding, may not be related to. Cervicogenic headache is more common in elderly patients where cervical spondylosis is more common. So cervicogenic headache, the difference between cervicogenic headache and migraine is cervicogenic headache is equally seen in male and female, where migraine is more common in female. Lateralization, this cervicogenic headache is unilateral without side shift. In migraine, it is 60% unilateral with some side shift, or sometimes it may be bilateral. Location is occipital to frontoparietal and orbital in cervicogenic headache, while it is frontal or periorbital temporal in migraine. The frequency is chronic episodic in cervicogenic headache. The pain character is non-throbbing and non-lancinating pain, usually starts in the neck, while the migraine headache is throbbing and pulsating. Triggers in cervicogenic headache, they are the neck movements and postures, limited range of motion, or pressure over cervical segments 1, 2, 3. Then associated symptoms are usually absent or similar to migraine, but milder degrees. Then there is decreased range of movement, while in migraine there is nausea, vomiting, visual changes, or photophonophobia. Then pediatric migraine and episodic syndromes that may be associated with migraine. So migraine is most common cause and accounts for more than half the cases of recurrent headaches in children. The risk of underestimating migraine in pediatric age is high. With such a high prevalence in school-age children, migraine has significant effect on school attendance and family dynamics involved in caring for a sick child, with loss of job productivity and work attendance in parents. Migraine phenotype differs somewhat in developing brain, and childhood episodic syndromes may arise before typical migraine headaches. And this may be confusion in diagnosing migraine. So diagnosing pediatric migraine may be difficult because of children's language and cognitive abilities. And adequate diagnosis is important to maintain a good quality of life and to avoid inappropriate therapy. Many childhood episodic syndromes have been described as common precursors of migraine. Diagnosis of childhood episodic syndrome is one of exclusion and involves a careful anamnesis physical examination, and appropriate neurodiagnostic studies to exclude other causes such as epilepsy, metabolic disorders, ischemic events, or psychological disorders. Epilepsy syndromes that may be associated with migraine are recurrent gastrointestinal disturbance. So the first is recurrent gastrointestinal disturbance. There are recurrent attacks of abdominal pain and or discomfort, nausea and or vomiting occurring infrequently, chronically, or at predictable intervals that may be associated with migraine. And examination, there is normal gastrointestinal examination and evaluation. Then cyclic vomiting syndrome. There are recurrent episodic attacks of intense nausea and vomiting, usually stereotypical in individual and with predictable timing of episodes. Attacks may be associated with pallor and lethargy. There is complete resolution of the symptoms between attacks. The cyclic nature is the hallmark and attacks are predictable. The onset of cyclic vomiting syndromes occurs generally before the age of 6 years, and the frequency of episodes varies between 3 and 12 per year. The median age for resolution of vomiting episodes is 10 years, and the 75% of the affected children will develop migraine by the age of 18 years. Then abdominal migraine. This is an idiopathic disorder seen mainly in children as recurrent attacks of moderate to severe midline abdominal pain associated with vasomotor symptoms, nausea and vomiting lasting 2 to 72 hours, and with normality between the episodes. Headache does not occur during these episodes, and most children with abdominal migraine will develop migraine headache later in life. Then benign paroxysmal vertigo. Here there are recurrent brief attacks of vertigo occurring without warning and resolving spontaneously in otherwise healthy children. Young children with vertigo may not be able to describe vertiginous symptoms. Parental observation of episodic periods of unsteadiness may be interpreted as vertigo in young children. Posterior fossa tumors, seizures, and vestibular disorders have to be ruled out in such situation. Then migraine in elderly. The prevalence of migraine in older patients who are in their 60s and 70s is significant, though less than younger cohorts, with both incidence and prevalence decreasing with age. Migraine is less typical in elderly and more frequently associated with vegetative symptoms. Accompanying symptoms of photosensitivity, nausea, and vomiting are lower in older adults compared with younger adults. Elderly migraine appearing to be more often bilateral and associated with what has become known as late life migraine accompaniments. Therefore, the diagnosis of migraine in elderly subjects may be more challenging, and many seniors with this primary headache can be misdiagnosed. Then what are these late life migraine accompaniments? Late life migraine accompaniments are transient neurological episodes in older individuals that mimic transient ischemic attacks, defined as passing neurological symptoms that can affect vision, speech, movement, and behavior. They are similar or identical to migraine aura. However, headache is associated with only 50% of the cases and may be mild. So the common migraine accompaniments may consist of visual symptoms such as transient blindness, homonymous hemianopia and blurring of vision, paresthesias, a heavy feeling in an extremity, brainstem and cerebellar dysfunction such as ataxia, hearing loss, tinnitus, vertigo, syncope, and disturbances of speech such as dysarthria or aphasia. The typical of migrainous accompaniments are the build-up and migration of the visual scintillations, the march of paresthesia, and the progression from one accompaniment to another, characteristics that do not occur in thrombosis and embolism. So it is obvious that in such situations, we have to rule out TIA, cerebral amyloid angiopathy, or SAH. But here, there is gradual build-up and migration of visual scintillations. There is march of paresthesia and progression from one accompaniment to other. This differentiates from this stroke or TIA or amyloid thrombotic episodes. So diagnosis is facilitated when two or more similar episodes have occurred or migraine-like scintillations are present. In summary, the migraine is a spectrum of disease symptoms. Awareness of its spectrum and associated symptoms, even in the absence of history of headache, is key to correct diagnosis. Patient history and correct interpretation of the symptoms gives the diagnosis, not lab test. So proper drug selection from prophylaxis as per associated comorbidities to prevent treatment failure. So if the patient's headache is accompanied by the following symptoms, suspect migraine first. So suspect is S is for sensitivity to light and or sound, U for unilateral or bilateral headache, S for stomach uneasiness, P for pulsating or throbbing headache, E for episodic headache, and C compromised quality of life, and T is for triggers. Thank you.
Thank you. Thank you, Vedis sir, for such a nice talk on this Sunday morning, giving us a time and giving your valuable all the information about the migraine. And sir, thank you for giving time to IMA Nanded and to all the participants. Around 200 participants are there. Okay. And thanks.
Good. That's good attendance.
Yes, sir. Yes, sir. Thanks to Johnson and Johnson for arranging such a nice event. And in India, I think around 24 crores people are having this migrainous disease, which are undiagnosed and untreated.
It's very common.
Yes, sir. Yes, sir.
Almost 80-90% patients, they are not diagnosed. Only 10% patients, they are labeled as migraine.
Yes, sir. And thank you once again from the IMA Nanded, sir. Now I invite Dr. Debashish Ruikar, sir, who is the leading neurophysician in Latur, and he is practicing at Latur in a Sri Neurocare, and one of the young chap who is doing a best work in Latur of neurology. And I again invite from as a president of IMA, he is from Latur for his talk on migraine prophylaxis. I will hand over this mic to Debashish sir. Debashish sir, you can start, sir.
Yes, sir. Very good morning. At the outset, I sincerely thanks IMA Nanded, Dr. Kadam sir, Dr. Bhede sir, for inviting me for this talk, and it was really privileged to be a part of this so nice and August. I have got long connection with Nanded because my education was at Nanded with Gujarat High School and all. So it's nice to be part of all so many friends around. So today we will be discussing in next half an hour or so regarding the migraine prophylaxis, the guideline-based approach, and actually the migraine is right now what we have seen. The migraine is one of the commonest medical comorbidities, and as we know, because it is one of the leading cause of neurological disease, it is one of the leading cause of the disabilities, because we all are worried about the disabilities. Why? Because any medical problem, whenever it is disabling, it has to be treated, and migraine is supposed to be one of the the third most leading cause of the disabilities in the world. So, because why it is the most disabling cause of disability? Because it suffers. Because migraine doesn't just cause headache, because it has got so many things. It will cause you to avoid your work. It will stop you, if you're a doctor, it will stop you focusing from your patients. If you're an office going person, you cannot focus on your work, you will take leaves. So you cannot focus, you can take leave, and so many other comorbidities with it. So most of the migraine sufferers, whenever they have got more attacks, say more than 4 attacks in a month or so, in that situation, their activity of daily living many times get hampered. So we have got many neurological disorders which will cause your disability. So here two are the most, which will cause a chunk of the disabilities. What are these two? One is stroke, which will take around 50% of the time. So 50% of the disability is a huge. So stroke is the leading cause of disability in neurology, say 50%, and the second most back to back is migraine. So migraine is not that it is you are getting just simple headache and so that you will take some painkiller and then you will go to work. It is not, because it will cause disability. And who is saying? The WHO is saying, and this is the one of the recent articles from the Lancet Neurology. So this 2017 Lancet Neurology article states that the second most common neurological cause of disability is the migraine. And then there is whole list of other things like epilepsy, the multiple sclerosis, head injuries, Alzheimer's, meningitis, motor neuron disease, Parkinson, and so many other things. What we are worried, they are all taking the backseat when it comes to the disability of and the problem of hampering of the activities of daily living. So it will cause you to adjust your daytimes. It will cause you difficulty in your day-to-day working. So it is not the loss of the person. It is ultimately the loss of the workforce. So ultimately, it has been found, again, same article from the Lancet Neurology. So what they have found out, finally, it is a loss of the work hour of the nation. And so finally, it will cause so when we talk of the global disease burden, it will cause so much problem in the global disease burden as well. So how much quality of life is getting affected? Now, say around 80% of the time, the person will say they have to go to the clinic. They cannot manage it at home. So around 90% of the time, the person will face, they have to go for a clinic for some or the other time. While 30% of the time, so 1/3 of the time, they have got emergency room visit. 5% of the time, they will require hospitalization. And on an average, 7 to 10 days leave will be taken. So for any government servant, 10 days are their casual leaves. So in the 10 days of the casual leaves, they have to manage their entire days, the casual, their all day-to-day activities, their functions, household functions. And out of that, if the 7 days are taken by the migrant, then it is something which is significant. So this is the, again, data from 2002 article, and roughly same is the true. So even if somebody coming from the clinical visit, or if somebody coming in emergency, it is not, the doctor is not sure whether he has got migraine or whether he has got meningitis, because then we have to find out the red flags. Sometimes it will turn out to be meningitis, sometimes it will turn out to be the sinus venous thrombosis, sometimes it may turn out to be SH. So if somebody coming with a sudden onset severe headache, many times it will be migraine, but still it will carry a red flag. So he has to get evaluations. Sometimes he will get admissions, so lab investigations, MRI brain. All these things will take a financial toll also. So whenever 1/3 of the time the person is coming from the severe headache in casualty, in that situation, the hospital admission and financial toll will again add to its disabilities. So financial burden as well. So it is not just a migraine, which is a headache, which will affect your, a little take a financial toll. It will lead you to take to the casualty. It will hamper your quality of life. So what are the barriers which will cause you find out the different aspects of the migraine? Because there are some doctor related barriers and there are some patient related barriers. So like Dr. Vedas has discussed few of the things, like sometimes sinusitis can present as a severe headache. Sometimes so many other causes, like so many facial pains can present you as a migraine. So facial related problems are that many times patient feels that their headaches are due to some simple eye related problem. थोडासा चष्मा लागला असेल किंवा जास्त मी वाचलोय, जास्त टीव्ही बघितलाय, जास्त मोबाईल बघितलाय. People will think like that. So they are thinking that's a trivial or simple causes, but in fact it might be a migrainous headache. Sometimes patient keeps on taking tablet. There's so many patients come in OPD and नाही या महिन्यात मला जवळजवळ दिवसात 3 गोळ्या लागल्या, या महिन्यात मला जवळजवळ महिन्यात रोजच गोळी घ्यावी लागली. So they will keep on taking the tablets, and whenever they come, and they are patients of medical overuse headache. So months together or weeks together they are taking tablets, and most of them what tablet they are taking is a painkiller. In fact, what they require is a anti-migraine tablet. So a lot of self-medications. Then one set of people will come, I have got fear of allopathic medicines, how often we have to use. And then in that situation, they won't come, they will stop prematurely, take some tablet for 10, 15 days, then they will stop. So any anti-migraine tablet taken for 10 to 15 days is not sufficient. It will take long time. And then what we typically see in our language also, what is called as doctor shopping. He goes to one doctor, 10, 15 days, he has got no relief, or he will get migraine. Again, he will go to another doctor. He will stop medications and he will keep on changing doctors. And there is so much fuss in his. And this is all recorded on paper and has been presented again in Lancet Neurology in the past. And there are some physician related or the doctor related issues, like in West, there are headache clinics. In India also now we have got headache clinics, and in the headache is one of the subspecialties of the neurology. So a lot of time, the person who is getting frequent headaches are referred to the headache clinics. And there they are totally managed and they have found out. And these people in US and Europe, they have got thousands of patients who are referred to headache clinics. And they have got 1 lakh patients data of migraine, 1 lakh patients of headache. And these sort of things are not possible in India, though we are the second most populous country in the world. So whoever these sort of clinics are not there, but still in Mumbai and all, the specialized headache clinic headed by Dr. Ravi Shankar sir also, and in our Indian Academy of Neurology also, we have got the headache as a sub-specialty nowadays started. So there are certain patient-related barriers for the control of the migraine. There are some physician-related or doctor-related problems. And finally, we have to treat the persons. So when we treat the patient, what is our goals of treatment? So our goal is to improve the quality of life. In which way? So we have to reduce the frequency, the duration, and the severity of the headache. So whenever the patient is there, we have to discuss with the patient that whenever possible, when he comes to the first visit, the headache is going to be there. Let's call it migraine. So you, me, medicines, and all our things, we are all the part of the team. So it is not you are alone. So one don't expect you will take a medicine for 2-3 weeks or 2-3 months also sometimes, and your headache will go forever. It is not possible. So there are some patient related factors, there are some lifestyle related factors, there are some medicine related factors. So everything taken together, we all are acting as a team. So as a team, we are going to take care of the headache. So you are important part of this management. I will be helping you. Medicines are forming an important part, and lifestyle related important things are there. So what are lifestyle related things? They are the trigger management and so many other things that we'll be seeing right now. So this all taken together will reduce the frequency, severity, and duration of your migraine. And despite that, once in a while headache will come, and that is okay. So ultimately, what are the things what we want? One, the person should not get the frequent headache. The second thing is that whenever the person gets headache, the target is that his headache frequency will. What is important for the patient? He wants to get headache. The analgesic acts, right from which analgesic acts, then paracetamol, omeflam, lot of neurologists use naproxen, and so many other painkillers. If the painkillers doesn't work, the second most important drugs which the neurologist use or the physician use are the triptans. So we have got whole range of triptans like zolmiptans, triptans, naratriptan, and so many triptans are there. Out of that, zolmitriptans and dizatriptans are the most commonly used triptans, and these are available in the form of tablets, orally dissolvable strips, in self-injectable medicines, or intranasal therapy. So many times if the person has got nausea, all these triptans sometimes works much better than the analgesics because they are the migraine specific things, but they are not very safe. The triptans, whenever we use them after the age of 40 years, we have to take a little bit pinch of salt, because if somebody is hypertensive, if somebody has got IHD, after 40, so many people are diabetic, IHD and all, the triptans can cause spasm of the blood vessels, and it can raise the BP for sometimes. It can precipitate the MI for some people or attack of IHD for some people. So the person should not be having asthma, the person should not be having hypertension or IHD, and after 40 triptans has got a little bit limited role. So analgesic and triptans are one of the important treatments in acute attack. While if the person headache doesn't respond to the analgesics and triptans, and still he keeps coming with severe headache, so we have to rule out the secondary factors, what we call as red flags, and if the secondary factors like CSVT and SH has been ruled out, possibly the injectable divalproate or the steroids can be given. The steroid to be only resort drugs to be given only with something called as status migrainosus. We know about the status asthmaticus, we know about the status epilepticus, so that there is status migrainosus, where a single dose of steroid can be used when all other factors have been ruled out. And we have to tell the patient that he has to strictly avoid the analgesics taken on regular basis. He should not be taking them on regular basis because it itself can cause medicine overuse headache. So the acute attack has been taken care. And the important thing the person has to understand, so it is not important that only acute attack has been taken care. So he has to take something called as migraine prophylaxis, and which are the forerunners to prevention of the headache. So what are the things, what are the medications which we use for migraine prophylaxis? So even though headache is not there, he will take say 1 or 2 medications long term. How long term? Say few weeks to few months as a prophylaxis, and that will help him to abort and to avoid the frequent headache spells. So which are called as prophylaxis. And these are the drugs which actually help in their important helping in the improving the quality of life. So why these things are important? Because if somebody has got migraine with aura, possibly they might get some changes in the MRI. There are some studies which tells that the frequent migraine spells can cause increase in the cardiovascular risk. So possibly they have got some roles in these two things as well. So which patient who is the best candidate who require the migraine prevention medications? So there are guidelines for them as well. So we have got the International Headache Society, and there are some different societies, and which keep on giving the guidelines as and when in between for this migraine prophylaxis guidelines. So the person who requires the migraine prophylaxis is who get more frequent headaches in the form of more than 6 headache spells in a month. Possibly he has got 4 or more headache spells or headache days in a day, which leads to him impairment of his activity. He is not able to work. He has to take leave. If a lady is there, she is not able to cook properly. She just goes and sleeps in a dark room. If a boy is there who is not able to go his school, if a doctor is there who is not able to focus his work, or he has got 3 or more headache days with severe impairment which require bed rest. So in that situation, they require migraine prophylaxis drugs. Then to whom prophylaxis should be considered? So in a patient having 4 to 5 migraine headache days with normal functioning, possibly 3 migraine headache days with some impairment, and 2 migraine headache days where they require actually the bed rest. In that situation, we will consider the person will require migraine prophylaxis drugs. And when it is not required, so if the person has got possibly less than 4 headache days, and which is not causing significant impairment of activity of daily living or the bed rest or so, in that situation, only analgesic tablet or only triptan tablet will be sufficient for him. So these are the people who will require the migraine prophylaxis. And how much should be the duration of the prophylaxis? Because many times we give some tablets for 1 week, 2 weeks, 4 weeks, and we stop. So what are the prevailing guidelines which tells how much time should the prophylaxis should be offered? So the American Academy of Neurology guidelines, which are one of the respected guidelines, which tells that whenever you choose a drug, that drug should be taken, the person should be on the tablet for not less than 2 to 3 months for optimal clinical benefits. So American Academy of Guidelines tells about 2 to 3 months of the prophylaxis, while the Canadian headache guidelines ask us to give at least 2 months of the migraine prophylaxis, choosing the optimal drug. Well, the European guidelines again say around 3 months of the duration. Italians and other guidelines again say 2 to 3 months. So ultimately, it takes 2 to 3 months of the medicines, which is optimally chosen drug for the person to get 50% or more relief of his headache. So what is the algorithm which is as of the prevailing guidelines at present? So first thing is that first start the treatment. So choose the patient to require prophylactic therapy. Once choose the optimal drug. Once you choose the optimal drug, use it for 3 months on an average. Some patient will require 6 months of maintenance, not all. And if the recurrence is there, check why he is getting recurrence and whether he requires more medications and what are the patient factors which are causing recurrence of the headache. So we will start slow, go slow, maintain properly, check out the triggers, check out the patient-related factors. A lot of time there will be anxiety, depression, other factors. We have to take care of the triggers as well. And once in a while headache is there, that will be okay. So this will be the rough algorithm of the management as per the current and prevailing guidelines. So there are some studies which tells that once you use the medicines for 3 to 6 months, some people will get long duration relief, some people still get headache recurrence afterwards. But 3 to 6 months might be required for some people. But not all people will require very long duration of treatment. Say 3 months will be adequate for most of the time. So there are studies which is present in the headache journal, which tells that so 6 months, some people stop after 6 months, and whenever these people have been started on the treatment, most of the time, say 50% or more patients will stop the treatment by the 2 months or so. So even if you are asking the person for taking, this is the European data. So even in Europe and America, whenever the patient has been offered proper prophylaxis by headache experts, most of the time the drug withdrawal, the patient stopping themselves are very common. And many times the patient doesn't adhere to the prophylaxis treatment. So this is a large data of 1 lakh patients. So this sort of large studies are not available in India of 1 lakh patients or 2 lakh patients. So whenever this is the European data, and what the data tells, say in a 1 lakh patients, the mean age was 41 years with 83% of the female patients. More than 80% of the time, the patient has not continued with the migraine prophylaxis for long term. So this is with the so-called developed nations. So in India, that is even more problematic because most of the time patient doesn't keep their medications for adequate amount of time. So they keep on getting the recurrent of the headaches. And the same thing about the American study. So the persistent, the continuation of the prophylactic treatment is not common in Europe and America, and same is true with India. So most of the time, the people will just continue for 2 months, 50% of the time. Only 25% when they required will continue more than that. And what is important, 41% of the time the patient will go back to doctor and they will require some sort of treatment by the end of 1 year. So it is not the problem with the patient is not continuing treatment. They will require some sort of treatment with migraine prophylaxis by the end of 1 year, say in 41%, which is a significant amount of time. And this is one of the recent data from culture 2 to 3 years back. So we have seen about the acute treatment. We have seen about the quality of life and what are our targets. Then we have seen about the duration of treatment and what are the guidelines tells about the duration of treatment and which are the predominant guidelines from the European. Naturally, Indian guidelines are not that much available. So what is the choice of treatment as per the current data? We all know there are category A evidence, category B and category C evidences. So the category A evidence is for beta blockers, calcium channel blockers like flunarizine and antiepileptic drugs. So these three category of drug has got the category A evidence. So the most standard evidence. Out of that beta blockers, propranolol is the largest using drugs. Metoprolol, cardiologists use a lot as antihypertensive. It has got the anti-migraine action, but possibly propranolol has got the better action. If somebody is the hypertensive and he has got migraine, possibly these two are the drugs which can be used with the category A evidence. The flunarizine, commonly known as the Cybelium, and the other market names are available. So they have got the category A evidence. While the antipsychotic, especially the divalproate rather than the valproic acid, and topiramate has got the category A evidence. So how to choose all of them? So because when we choose optimally, there are some patient factors. Say if the patient is obese, if the patient is, most of the time migraine is common in the ladies, and that too in the young ladies who are in their primes of life, say college going girls who is just recently married, who is about to go for pregnancy, who is recently married. So the childbearing age group is the largest chunk of the girls or ladies who is getting the frequent headaches. And in that situation, possibly the antiepileptic drugs like topiramate and divalproate are not a choice of drugs. Why? Because the divalproate or valproic acid, which cause weight gain, can cause PCOD, can cause tremors, can cause weight loss, can cause pimples. So a young girl, divalproate may not be a great option. It can be a great options before or after that. Or if somebody has got mood problem, then the divalproate has got mood stabilization. In that situation, we can use them. So a lean, thin male who has got some mood-related problem, then that situation divalproate is a better option. But if a young girl who is about to get pregnancy, who is obese, in that situation divalproate is not a choice of drug. So is the case of topiramate. Topiramate is an excellent drug. It is a very good drug whenever it comes to chronic persistent migraine. So if somebody's headache is persistent, not getting stopped, in that situation topiramate is the drug, but it should not be used in a person who has got renal calculi, or in the long run, topiramate itself can lead to renal calculi. So whenever we put a topiramate, we ask the person history that it should not be having history of renal issues, especially renal calculi in the past or recent. Secondly, there should be no history of acute angle closure glaucoma, or there should be any ophthalmological issues as such. And sometimes topiramate can cause a little problem in the form of behavioral or in the form of calculations also, because topiramate can cause a little bit changes. Sometimes it can cause change in the color vision as well. So I have got one or two patients who were actually a stockbroker, who has got severe headache. He used to keep on getting headache. Started him on the topiramate. He came back after 2 months and he said that with the topiramate, my headaches are much better, but somehow I don't know. I'm making mistakes in my stock selection, in my calculations, in my focusing in my stock broking problems. We have stopped the topiramate and he was able to do. I got one medical student who have put him on topiramate and he said that his viva was not great this time. So topiramate can cause a little bit impairment when it comes to the high-end mental functions. So can cause weight gain. Can cause a little bit of the sleepiness, for dizziness for sometimes. And when metoprolol, beta blockers, they are not great drugs if somebody having asthma or heart attacks. Like if somebody having cardiac issues, metoprolol is better, but propranolol is not better. So it is not great drugs for somebody having peripheral vascular diseases, asthma. In that situation, these are not. So they are the good drugs for migraine, but for all these three drugs, we have to choose the patient with his other comorbidities. Why? Amitriptyline, nortriptyline, and these TCAs, the tricyclic antidepressant, they are one of the wonder drugs when it comes to patient having sleep-related problems, not getting sleep. They have got migraine with anxiety and depression. They are excellent drugs. They have got category B. We can use them for long term. Similarly, desvenlafaxine, hardly we have somebody will be using it in migraine, but if lot of times, say 1/3 of the migraine patients will be having anxiety and depression. In that situation, desvenlafaxine or venlafaxine is a good drug. There are other molecules like petasite. There are American studies. Petasite is one of the herb, and the herb extract can be used as a migraine prophylaxis with the 30 to 40% of the efficacy of the migraine. and sometimes bisoprolol also can be used whenever the hypertension is there. But all these three have the officially category B evidence. Well, there are n number of medicines available. So there are actually 20 to 25 medicines available with category C evidence. So there are medicines which are commonly used like magnesium, riboflavin, coenzyme Q10, lisinopril, sometimes methotrexate. They have proven, but with a category C evidence. So they have got some of the other things like methotrexate if used, they can cause the pulmonary fibrosis or the retroperitoneal fibrosis. Coenzyme Q10 is a reasonably costly drug at 300 milligram, and the efficacy is only say around 30%. Riboflavin is good, especially in the females who is pregnant. You can use magnesium and riboflavin because they are safe in pregnancy. So they have got a place, but it's a specific niche area. So there are host of the drugs. So category A drugs are the first option. Naturally, category B drugs are the second option. Category C drugs, they have got some specific use in their day-to-day clinical practice. So we will, as we have seen some time back, for the few of the drugs, we will go in little detail, which are the commonly used drugs. Like flunarizine is a calcium channel blocker. And nowadays, there is a concept that there is something called as calcitonin gene-related peptide called as CGRP. So CGRP will get increased in the CSF, and the CGRP will get blocked, and its its level will be reduced whenever you use the anti-migraine drugs. So CGRP has been taken as a marker of migraine. In other type of headaches, the CGRP doesn't increase, and in migraine-specific headaches, CGRP will increase. That's what the current guidelines say, like 2020 guidelines, the data says. And in US and European market, the anti-CGRP medicines are available in the form of monoclonal antibodies or tablets. They are available in acute and chronic prophylaxis as well. So the CGRP medicines are not available in India. Soon they will be make it available in India. They are reasonably costly, but possibly they will having their own. But the CGRP levels will get reduced whenever the migraine will get reduced. And anti-migraine medications will reduce the CGRP levels. So flunarizine versus propranolol. So the rate of responding for the flunarizine is say around 70% of the time, and when it comes to propranolol, it's around 50 to 60% of the time. This is an old study, but still the same data holds true. So 10 milligram flunarizine vis-a-vis taking propranolol is 80 milligram of propranolol. They have used the duration for 4 months, and after stopping also the persistent benefit goes with the flunarizine as compared to the propranolol. And same holds true about the tricyclic antidepressants and topiramate. So whenever we use the medicines for 1 to 3 months, the attack frequency will get reduced, and it is called as residual benefits. The residual benefit will get persistent a lot of duration of time, say around 6 months to 1 year also, whenever they have used for 3 months or so. So we have seen about the residual benefits for number of drugs like topiramate, anti-epileptics, the flunarizine. Even after drugs stop, residual benefit is there for long time, provided you have used for reasonable long time, say 2 to 3 months. So what are the guidelines which recommend flunarizine? So number of guidelines, European, American, Singapore, Italian, and Indian guidelines also recommend flunarizine as a category A evidence. So what are the role of topiramate? As we have seen, the topiramate has got its role in, especially in chronic migraine, if other medicines are not required in a chronic persistent migraine. But the main thing with the topiramate, the renal calculus should not be there, and more important than that, once you ask the person about topiramate, you tell him next 3 months, 3 weeks or so, if his headache get worsened and he has got any visual problem, come back immediately. Possibly the acute angle closure glaucoma might get precipitated with the topiramate, and if not treated in time, he will require a laser treatment. So whenever you ask the topiramate, tell him he might get worsening of headache, and in that situation, if the glaucoma gets precipitated, the topiramate is lifetime contraindicated, and then he will require some other treatment. So it has got one role in a special population, but it is an excellent drug, but the proper patient should be need to be checked. It has got more responder rate. more than 70% many times, and topiramate can be used for long term. So imagine if you use for more than 1 month, significant weight gain can be there. But topiramate indeed can cause weight loss. Rather, it is a recommended drug for weight loss. So obese person, topiramate is a choice of treatment. If chronic persistent migraine, topiramate is a choice of treatment in a selected patients. And significant weight loss will be reported by the topiramate when we use say 50 or 100 milligrams per day. So we have to start slow, very slow, go very low, and slowly upbuild the dose and maintain the dose. That is the treatment for the topiramate. So what we have seen just now is it starts slow and goes slow, which generally works better with the topiramate, and which works for many of the other molecules as well. So as we have seen, there are certain guidelines. So the recent guidelines in 2019 guidelines, which tells that there are apart from this medicine, there are some pitfalls in the management. What are the pitfalls? First, apart from medicine, the trigger management should be there. A lot of times the patient will be having comorbidities in the form of anxiety and depression, which has to be taken care. If the person is anxious, suppose somebody has got his exams approaching, some girl is there who has recently married and that is causing him subconscious stress, that is again actual trigger. Somebody in lot of time in Indian concept, many times people will keep on fasting, and the fasting itself acts as a trigger. Sometimes patient goes for some touring or traveling and it will act as a trigger. So smells, traveling, fasting, they are the common triggers and they have to be avoided. So the trigger management, the comorbidity management is important part of the migraine prophylaxis, and which has to be taken care. So person has to know his triggers and they have to be avoided. For sometimes the food is a trigger, sometimes alcohol, beer, sometimes curd, dahi, chocolates, some particular food like sweets or bitter foods can be actually a trigger, so they have to be avoided. This is one. The second thing is that practical expectations. As we have seen initially, we will tell that the person that migraine is not something which will cause you a lot of problem, which will cause you kill you like stroke, but it will cause you problems. So what migraine, this thing, we all are part of team. I am part of team, you are part of team, you are all household relatives, say if wife is there, her husband, and all, we are all part of team. So medicine is an important thing. So 50% medicine will work, but we are on the practical expectation. We won't expect the effort together. We think that it should not trouble you. So the practical expectation should not be there. We'll use adequate amount of things and taken this entire team together. We all are going to fight with the thing, migraine, and you are going to be better. So don't worry. But once in a while headache is there, in that situation, taking 1 tablet of analgesic or treatment will be okay. And one of the target is that we will avoid the adverse event of the medicines as well. So finally, migraine is one of the most common debilitating disorders in the world, in the India. Say third leading disabilities as per the WHO, and second most common neurological disabilities. We will discuss with the patient, and after discussion, we will find out the comorbidities, the triggers. They will be taken care, should be adequately. The person will be discussed about the drug and his acute and chronic problem both. The person should know only analgesic tablet is not the thing which helps migraine. He has to take a little long-term medications, manages comorbidities, and his triggers should be get managed. There are a number of things. Category A drugs are the best options, then category B and C naturally. And migraine prophylaxis will go for not few weeks, but few months. Then residual benefits might be expected. And this is a teamwork. And this is the wonderful teamwork. And if everything goes smooth, he will definitely get relief from his headache. So we want everything together. So it is you and me. It's all the team. So is this thing. And we are going to fight it together. So I sincere thanks for IMA Nanded, the team IMA Nanded, and everybody for making me part of the event. Thank you for you all being here.
Thank you, Devashish sir, for such a nice and informative talk from you. We expect more and more talks in the future like this for the Nanded IMA. And now I turn on to next speaker of the day. Before that, I will like to announce one thing for the members who have joined from the DigiShield, that you should give your name and registration number in detail while making the payment. And those members who are not paid and joined the meeting can pay later with the IMA Nanded, but they should give their registration number and all the details in a right way on the form which is written in the registration of MMC. Now I hand over this whole scene to Dr. Pramod Dhonde, who is a leading young neurophysician in Nanded. And their specialty of Dr. Pramod Dhonde is that yesterday was a Environment Day, World Environment Day. He is more interested in plantation, and he has planted more than, I think, 1,000 around trees. And he is making all the environment in the Nanded very lively, and best wishes from IMA Nanded to his future works. And I hand over this to Dr. Pramod Dhonde, sir.
Am I audible?
Yes, sir. Yes, sir. You are audible, sir.
My screen is visible.
Sir, you start your video, sir.
Yeah. Okay. My video is there.
You are not visualized, sir, but this one is there. The presentation is there.
Sir, your presentation is there and your screen is also
yes.
visible.
Now you are sharing screen, sir. Okay.
At the foremost, I thank IMA Nanded and our very active president of IMA, Dr. Suresh Kadam, sir, who is very much active in academics as well as in social activities, as well as he is active in politics also, but for doctor's help, not for his personal gain, I think. And I just go on to this talk directly. So this is one of the very common thing, epilepsy, and I hope I would be helpful in a day-to-day practice for this epilepsy management. So I just move on to this talk. So overview is management. I'm going to talk about how to diagnose and what kind of epilepsies are there, and treatment part, and accordingly the treatment part, how it has to be chosen. So this was Jackson, the definition of seizure, which has been given in 18th century, where there was no EG, there was no MRI, there was nothing, no investigations were there. And at that time, there was only the thinking process was there, the patient was there, and clinically they were establishing the diagnosis. So what he was saying about the seizure, this represents a crude hyperphysiological state, which I speak of as being highly unstable. The discharging lesion is of a few cells which have gotten for the above rest of the cortical cells in degree of tension and instability of equilibrium. The lesion is made up of cells of nervous arrangements which represent some special movements of a particular muscular region. The sudden and excessive development of these movements and discharge of those cells is the convulsion incipient, or if there be no spreading of the spasm, it is the convulsion total. So this is the exact definition which is still exists and which is matches with the what seizure is there. So how he could have thought of this and how it has been emerged as the same thing here. It's amazing to see how Evelyn Jackson has made the diagnosis of seizure and definition of seizure in those days. So what is the demography? I'm just a little bit talk about the demography, why it is important, because we should know what we are treating and how many people are having affected with this dreadful disease. The epilepsy affecting almost 50 million people worldwide, 5 million of whom have seizures more than once per month. Approximately 85% of the people affected with epilepsy live in developing countries. 2 million new cases occur in the world each year. This is from WHO side. Recent studies in both developed and developing countries have shown that up to 70% of children, adults newly diagnosed with epilepsy can be successfully treated. That is, their seizures can be completely controlled for several years with anti-epileptic drugs. After 2 to 5 years of successful treatment, drugs can be withdrawn in about 70% of children and about 60% of adults without relapse occurring. In the case of treatment failure, why it is important to understand? Because if the treatment failure is why it is treatment failure is there, it is crucial to establish whether the failure is a result of inappropriate drug selection, inappropriate dosing, refractory disease, or poor adherence to the therapeutic regimen. Nowadays, also we are seeing people taking garoin, the drug combination of this phenytoin and phenobarbital, which is still used and which is not a rational combination to use. Still, it is very effective combination, but the side effect profile and all these things, the tolerability with this drug is very poor. So that this should be avoided in nowadays, because there are a lot of better drugs which are available, which can cure the epilepsy also, which can treat effectively epilepsy also, and which can control epilepsy also. So this is one of the articles from India only, my teacher, Dr. Khadilkar sir. So between the person and the pill, factors affecting medication adherence in epilepsy patients. The conclusion of this study is, this is around 330 epilepsy patients were regularly attending at an OPD clinic, were given a survey, and the questionnaire resulted that ensuring that anti-epilepsy drugs remain available in the public sector and are making them more affordable in private sector are the main interventions likely to improve medication adherence in clinical settings such as ours. So the main factors found to impact the medication adherence were duration of non-availability of medication in the public sector, monthly cost of the medication in the private sector, overall therapy-related, health system-related, socio-economic and psychosocial variables were not found to be significant determinants of the medication non-adherence in the setting. So in public sector, if we see in the suppose medical college Nanded or JJ Hospital Mumbai, there are now drugs which are available are eptoin, carbamazepine. Sometimes I think valproate is also available. So eptoin, carbamazepine, these are the drugs. But other drugs which are such as like valproate, then levetiracetam, then topiramate, zonisamide, these drugs also has to be used, and they should be made available in these public sector hospitals, because I don't think that can't be done by the policymakers. And that can be more effectively control the epilepsy in overall. So how to diagnose? Basically, these are demographic factors. How to diagnose? Basically, it depends on history, imaging, and EEG as in total. The main diagnosis still depends on the history. So epilepsy evaluation, how to evaluate the epilepsy patients? So first is, what is the epilepsy type? First is whether it is epilepsy. When it is confirmed it is epilepsy, what is the epilepsy type? Whether it's a focal or generalized. Presence of a specific epilepsy syndrome, that is supposedly juvenile myoclonic epilepsy, then childhood absence epilepsy, then you have say G1 syndrome. These are typical syndromes where there are typical seizure symbologies are there, and you can correctly diagnose and correctly give the proper treatment when these syndromes are defined. Focal, if it is determined if frontal, temporal, or parieto-occipital, or laterality, that is right or left. Frontal, suppose patient has this temporal lobe epilepsy, they will have typically epigastric pain like sensation, epigastric fear like sensation, and after that patient will have some focality, and then after that generalized tonic-clonic seizures. Suppose frontal lobe seizures are there. From frontal lobe seizures, you get very significant hypermotor behavior. Hypermotor behavior is like that patient will have very high quality, this flinging movements of the limbs, and there will be shouting and all these things like that. And after that, there will be tonic-clonic seizure. So these are the things where you should know that what the origin of seizure is there, and which kind of, which be right or left, that also you can classify, so that focality and whether it's a specific epilepsy syndrome. This is the first thing. Then seizure type, seizure description. Patient and witness reports, descriptive seizure classification, and EEG findings, whether the EEG is done intactly or ictally. Then ILE classification, whether then you should understand whether in which class this is fitting into, and accordingly the frequency, triggers, timing, awareness of events, risk factors, all these things should be noted down when the seizure type is identified. Then we should go for the etiology. Etiology, whether it's a structural, suppose patient has scar epilepsy, then whether it's a tumor, whether it's an infection, all these things has to be categorized. Metabolic like supposedly diabetes patients are there, and certainly uncontrolled sugars are there. In those patients, you will get epilepsia partialis continua. Mitochondrial disorders are there. You can get this etiological, various types of epilepsies. Then genetic, there are some mutations like SCA1A, then KCNQ1. These epilepsies are needed to be identified, because why? Some particular disorders, suppose patient has got this SCN1A loss of mutation, where you have to give this, you have to avoid this sodium channel
and gain of function mutation like Dravet syndrome to use sodium channel blockers. So that genetic epilepsies are very necessary nowadays to identify, because there are particular target oriented medicines can be given those kind of epilepsies. Infectious, obviously, if it is tuberculoma and neurocystic cirrhosis, these are common causes in India. Immune mediated, I will go into the later causes, immune mediated and unknown. Comorbidities, like suppose patient has additional comorbidities, like sometimes patients have got epilepsy, but along with that there are non-epileptic events also. Many times you can't identify those non-epileptic events. You get confused by these non-epileptic events, and you, in those cases, you don't need to increase the dose of antiepileptics. You have to increase additional antipsychotics, psychotics or small antidepressant to be needed to be added in those patients. And you should ensure that these are non-epileptic events, and you should not worry about this epilepsy, because many a times epilepsy patient, then relatives are very much worried about any type of episode which they consider it as epilepsy, but many times it can be non-epileptic also. Associated depression, anxiety, attention deficit hyperactivity disorder. Depression definitely correlates with the decreased intake of the drugs, then unknown timings and this irregular sleep. This can aggravate the epilepsy. Migraine also, there is one entity called migralepsy, where you can get combination of headache and epilepsy. Sometimes after headache means attack of epilepsy, you get severe headache. So supposedly parieto-occipital epilepsies are there. So these are comorbidities along with epilepsy, cognitive impairment, mortality, and SUDEP. SUDEP is a sudden unexpected death in epilepsy. This can happen. It's a very rare event. There it is supposed to be some cardiac dysarrhythmias while the attack of during the attack of epilepsy. This is one of the entities that is little but worrisome in the patients of epilepsy, but very, very, very rare to see. So I'm just going to show you one case, first case. This is an elderly male with history of these abnormal movements since 4 days, and his blood sugar was normal. What I see is the left index finger movement, that is extensor movements are that, predominantly extensor movements.
अचानक चालू झालं
हा अचानक हे 2-4 दिवस दुखलं ते आम्हाला वाटच नाही बसलो.
See what you are saying, this is like episodes are, so I haven't taken it like seriously. This is happening intermittently, and again it is getting having more episodes. So what this patient was having, this is a right-sided parietal infarct in a precentral gyrus. What you are going to see is a high parietal precentral gyrus on the right side. There is hypodensity on the right side, and that is correlating with the left-sided extensor type of seizures that is affecting only index finger. So this is the normally the corticus. If it is infarct, is there usually infarcts don't have seizure as one of the presentation. This is one of the rare presentation, but they should not be missed out. Normally, the corticospinal tracts maintain the extended and abducted position of the fingers. Loss of corticospinal tract, as in stroke, will cause flex pushers. Whenever there is loss of corticospinal tract, you will get the pronator drift. There is some flex movement of the hand. All these things happen. But in this patient, there was nothing like that. It was mainly this extension and all these things were there, and that is happening intermittently. Again, it is resulting. But there was not of infarct size is lesser. That's why it doesn't happen into the weakness part. While in epilepsy, with hyperexcitability, the neurons will cause either extensor or abductor just as seen in this case. So the first case I'm telling about this focal epilepsy. Again, I will go into the this is ILE classification. This is the classification which we have seen in this our medicine book Harrison, and this classified as partial, then simple partial, and then complex partial seizures and partial seizures evolving to secondary generalized seizures. And second classification is generalized seizures. It is again classified into subclassified into absences, myoclonic, clonic, tonic, tonic-clonic, and atonic seizures, and unclassified epileptic seizure. So this was the 1981 ILA classification. Now 2017, ILA has come with this advanced version of the classification, which is again defining into focal, generalized, and unknown. Focal again into aware and impaired awareness, and generalized into motor and non-motor, unknown, motor and non-motor. So this is basically defining purpose is that it has to be only mainly focal versus generalized. And again, it is again divided into motor onset and non-motor onset. So in nutshell, what we are seeing is the focal, generalized, unknown. then epilepsy types, focal generalized, combined generalized and focal unknown, and again epilepsy syndromes. And the etiology wise, we have to see these metabolic, structural, genetic, then immune and unknown things. So this is another case I'm going to talk about. She is a 41-year-old right-handed woman presented for evaluation at epilepsy clinic. And 3 weeks earlier, she had collapsed and convulsed on a saucer football saucer ground during a hot summer day. She remembered at the field watching her play and walking around toward the other side of the field and then losing consciousness. She was unaware of what happened when she arrived in the emergency department. There was no witness report. She was thought to have a syncopal event, given the circumstances as well as the results of the normal EEG and brain CT in the emergency department. During follow-up in an epilepsy center, it was revealed that the patient had asked a witness who had seen the event, who described how the patient collapsed to the ground, became rigid, and then started convulsing more than a minute. Afterward, the patient appeared confused and incoherent. So these things, whenever you are not sure what has happened, try to see who has seen the case. That is most important thing, whoever might be there. Nowadays, the mobiles are easily available. So you should tell that, try to video record the episode so that it is better to understand the semiology of the thing. Then this patient remembered on the further questioning, she had really a weird feeling of sudden strong fear for about 10 seconds right before she passed out. The patient had distinct fear before 1 to 2 times per year for the last 4 years. She was typically able to calm herself down with a few deep breaths, usually lasting for a minute or less. During some of these episodes, she had told her husband that she felt weird, and when he checked on her, she seemed to be always to be able to respond. This had happened while running, but also when resting. Brain MRI had been done in the interim and was initially interpreted as normal. On further review, her brain MRI was found to have demonstrated 6 mm, a small ovoid signal abnormality to the right middle temporal gyrus. Within the subcortical white matter of the right and middle temporal gyrus, there was a region of T2 flare smaller cystic component with the hypointense stem. This likely represented a focal cortex dysplasia or glioneural tumor. Subsequent 36-hour ambulatory EEG was read as normal. So this was a MRI. You see the right-sided lesion here, right temporal, medial temporal, the middle temporal gyrus. And this case illustrates the different aspects of the seizure history and common pitfalls, such as missing a history of prior auras, overlooking a subtle lesion on brain MRI, and the option for early surgery to understand the etiology and distinguish benign versus potentially malignant underlying pathology in the selected candidates. So this case has taught us that regarding, we should not first, history has to be very accurate. History has to be taken by this. If the relative or someone is there, then you should take the history from that perspective. Again, you should, if you are not sure, retrospectively ask about the similar events and all these things are there. Second thing, whenever you are doing an EEG or MRI, you should say that most of the time you should advise at least 3 Tesla MRI with thin cuts. And sometimes there are some typical sequences are there, SPGR sequence and all these sequences are there. We should understand some cortical dysplasia, small tumors that can be missed on this CT scan definitely, but on 1.5 or 1.5T or even 3T MR also when these are overlooked. So that this should be seen very carefully whenever you are seeing in some certain about the seizure semiology that it's focal in onset. So seizure symptomatology, then again it is is divided into subjective and objective. In this patient, what we have seen is subjective aura, that is somatosensory, visual, auditory, olfactory, gustatory, epigastric, cephalic, autonomic, and psychic. These are the subjective, means patient feels by herself or himself. Objective, that someone has seen non-motor, altered awareness, responsiveness, aphasia, amnesia, delirium. Elementary, automatism, or hypermotor, and negative. Elementary, that is myoclonic, tonic, clonic, tonic-clonic, versive, epileptic nystagmus, epileptic spasm. These are the motor manifestations. Automatisms like manual, pedal, mimetic. There are some, then hypermotor as seen in frontal lobe epilepsy. Negative, that is recurrent false, that is atonic, astatic, hypokinetic, and akinetic. So these are the seizure symptomatology, subjective and objective seizure symptomatologies. So you have to deeply ask and you should know what is happening to the patient while during the aura as well as during the phase of seizure. So this is another case, case 3, 18-year-old female presented with history of myoclonic jerks with history generalized tonic-clonic seizures since 2 years. She was treated as MR negative epilepsy with levetiracetam, carbamazepine, clobazam since 2 years. Not well controlled. She was having almost, when she came to us at that time, she was having almost daily episodes of seizures, daily episodes of falls, and intermittently generalized chronic seizures. So her initial EEG was normal, and now her EEG is showing this is generalized spike and wave discharges 2 to 3 hertz, and which is indicating that she is having idiopathic generalized epilepsy. And what was the wrong in her medications? If you see the previous slides, what I'm again telling you, she was on levetiracetam, carbamazepine, and clobazam since 2 years. So it's an idiopathic generalized epilepsy that is aggravated by carbamazepine. So whenever you are seeing this generalized spike and wave discharges, at that time, these patients should be avoided with sodium channel blockers, that is carbamazepine. And carbamazepine is aggravating her epilepsy so that she is having almost daily falls. Now she has been we have put her on valproate and levetiracetam combination, but still she was not controlled. Now we have shifted to valproate with lamotrigine. Now she has well-controlled seizures. Valproate and lamotrigine is the most synergistic combination, but you have to be careful while using lamotrigine because it can cause sometimes Stevens-Johnson syndrome, sometimes skin rash, all these things. But still, it's a very good combination to use when the patients are having refractory seizures, particularly idiopathic generalized epilepsies. Oh, I'm just giving you them one example. This is hyperventilating. If you can make out. What is she having?
नाव काय तुझं?
Blank.
इकडे बघ, नाव काय?
She is
सांग
not
मला तुझं नाव.
unresponsive. And again, she becomes okay.
हां, करा बघा.
Now she, this girl.
बळ पकड इथं. पकडा. मार बघ जरा.
Hyperventilating. Now see. Again, blank looks, slight uptolling, unresponsiveness.
ताई नाव सांग. ताई जीभ दाखव. जीभ दाखव ताई. जीभ दाखव ताई. नाव सांग. जीभ दाखव.
So this is a very typical absence seizures. You should understand what is absence epilepsy, because in this case, if you use eptoin or carbamazepine, you are making her life very hell of a life, because this will aggravate her epilepsy, this will aggravate her absences, this will aggravate her whole personality. She will not be able to go to school. She will be cognitively impaired. So in those cases, you must avoid this carbamazepine and phenytoin or sodium channel blocker drugs. So what is idiopathic generalized epilepsy? I'm just giving you one of the brief review of this IGEs. The estimated proportion of IgE amongst persons with epilepsy is around 15 to 20%. Population-based studies of new onset epilepsy in children and adolescents have found that 23 to 43% have generalized epilepsy, and of these 53 to 58% have one of the IgE syndromes. IgE syndrome differ in their age of onset, which typically ranges from 3 to 25 years. Rarely onset can occur as late as 40 years. Onset after this age is exceptional. The IGs are basically characterized by EEG, typical EEG abnormality of 2.5 to 3 hertz, generalized spike and wave, MR negatives. Now the ILA is saying that whenever you are seeing these typical abnormalities on the EEG, it is not necessary to even MRI also. So that if you are saying IGE, first identify the semiology and then try to do a sleep deprived EEG. And if you will get the discharges, try to avoid sodium channel blockers in those cases. So this is a 2021 concept of generalized epilepsy, because we should know that this is not still into practice, but this might come into the practice and classification. So idiopathic generalized epilepsies, if you see the 4 squares here, there are 4 classes of epilepsies in the idiopathic generalized epilepsy. That there is childhood absence epilepsy, juvenile absence epilepsy, juvenile myoclonic epilepsy, generalized tonic-seizure seizures alone GTCA. So these are 4 IgE are there. Then again, these other types of epilepsies like myoclonic atonic epilepsy with eyelid myoclonia, that is Giron syndrome, epilepsy with myoclonic absences, myoclonic epilepsy in infancy, and genetic epilepsy with febrile seizure plus, JEF plus. These, along with this developmental epileptic encephalopathies and developmental encephalopathies, this is a broader category of generalized epilepsy where you get this 2.5 to 3 hertz of generalized spike and wave discharges, along with some genetic mutations. If you can find, then you can say it as a generalized epilepsy. So I'm just going to give the MCQ, and at the end, if you could type me out what is the answer of this question. Which of the following seizures types is not seen in the genetic generalized epilepsies? First, absence seizures. Second, generalized tonic-clonic seizures. Third, myoclonic seizures. And fourth is focal aware seizures. I will ask in the end of this talk what is the answer of this. So, clinical presentation, I am going to come to this differential diagnosis of epilepsies. The clinical presentation of epilepsy in relation to the differential diagnosis. So these are the various scenarios where you see this epilepsy in combination with some other diagnosis. Loss of awareness can be seen in epilepsy, can be seen in syncope. Generalized convulsive movements can be seen in epilepsy as well as in syncope, as well as one of the entity called limb shaking PIA, where you can see the generalized convulsive movements, where it can be unilateral or sometimes bilateral. Focal convulsive movements, this can be seen in syncope also. Facial muscle and eyelid movements, this can be seen in some of these dissociative seizures also. Drop attacks, this can be functional, or some central nervous system pathology like colloid cyst of the third ventricle. Transient focal sensory symptom, transient visual symptom, transient vestibular symptoms, psychic experiences, aggressive outbursts, episodic phenomenon, sleep, prolonged confusion, or fugue states. These are the presentations where you can have multiple etiologies apart from epilepsy also. So this is the common thing what we see, epileptic versus non-epileptic attacks, that is called dissociative seizures. The basic difference is the precipitating cause is very rarely seen in epileptic seizures. There is definitely some dissociative component, is common emotional or stress related event happen prior to this dissociative seizures or non-epileptic attack, we can say. When alone or asleep, commonly seen with epileptic seizures, may be reported in dissociative. Onset usually short, maybe short or several minutes in functional. Aura, various, usually stereotyped in epileptic seizures. What we have seen in the first case, these are stereotyped movements. So you cannot mimic it like that. Fear, panic, and altered mental state, these are the auras seen with dissociative seizures. Speech, cry, grunt, or at onset muttering words in automatism. Semi-voluntary, often unintelligible in dissociative seizures. Movements, atonic, tonic, if lonic, synchronous small amplitude jerks. Asynchronous flailing of limbs, pelvic thrusting, opisthotonous. The whole pelvic thrusting, opisthotonous. These are the very characteristic feature for dissociative seizures, which is very unlikely seen with epileptic seizures. Whenever you are seeing this pelvic thrusting, opisthotonous, to say it as more of a dissociative rather than epileptic. Injury, tongue biting, fall, directed violence. There might be tongue bite in this dissociative seizures. Cheeks, lips, hands, throw self to the ground. Direct violence is not uncommon. Consciousness, complete loss in generalized tonic-clonic, maybe incomplete in complex partial, variable, often inconsistent with the seizure type. You may or may not see, and there is very different variable features we will see in the dissociative thing. Response to stimulation, none in generalized tonic-clonic, may respond in complex partial and postictally. Often reacts, and this may terminate episode. Whenever you are having confusion, whenever seizure and dissociation, this is a very important point. If patient is, you ask the relative or something, that ask the patient or himself or herself that whether you are audible, whether you are understanding what we are seeing during that episode. If she says or he says that she understands, then many a time this can be dissociative or non-epileptic event. If it is not, she is not understanding at all, then this is one of the favoring features towards epilepsy. Incontinence is common. Sometimes this can happen in dissociative. Duration few minutes may be prolonged in dissociative seizures. So this is the differential diagnosis, what I was talking about. This is one of the main differential diagnosis and I was talking about. So this is a broader category of drugs which you should use in this generalized versus focal. I'm just talking about the generalized and focal epilepsy. So absence epilepsy, if it is absence, classical absence, which we have seen, what I already shown the video. The ethosuximide, lamotrigine, ethosuximide is the first drug of choice, but it is, if a patient is having associated generalized tonic-clonic seizures, so it is not a good drug to give along with this. Only absences are there, then definitely it is one of the wonderful drugs to control. Ethosuximide, then lamotrigine and sodium valproate, the first choice. Then second choice, clobazam, clonazepam, topiramate. Third choice, phenobarb. And drugs to be avoided. Avoided are these list is very important. Because the absences you give this carbamazepine, gabapentin, oxcarbazepine, pregabalin, tigabalin, vigabatrin, these drugs definitely will aggravate her seizures and this will land into more cognitive decline. Myoclonic, Myclonic, first drug of choice is levetiracetam, followed by sodium valproate, then topiramate. Then second drug, clobazam, clonazepam, lamotrigine, piracetam, and zonisamide. And drugs to be avoided, again, carbamazepine, gabapentin, oxcarbazepine, pregabalin, tigabalin, and vigabatrin. So these drugs to be avoided because they can aggravate the myclones and myclonic epilepsy also. So these are the generalized epilepsies I'm telling about that. The first drug to be used are sodium valproate and levetiracetam. These are the drugs to be used in generalized epilepsies, and along with some cases of absences, this ethosuximide and topiramate. Then focal epilepsy. Focal epilepsy is cryptogenic, any type of focal epilepsy, what we have seen initially. Carbamazepine, lamotrigine, levetiracetam, oxcarbazepine, sodium valproate, and topiramate. These are the first drug of choice. Second drugs, clobazam, clonazepam, gabapentin, perampanel, phenytoin, pregabalin, zonisamide. Third, acetazolamide, clonazepam, felbamate, gabapentin, phenobarb, primidone, and vigabatrin. First drug is carbamazepine. Second, then lamotrigine, levetiracetam. These are the drugs to be preferred. Oxcarbazepine, sodium valproate, and topiramate. The drug to be chosen according to patient's physique, patient's behavioral issues, associated cost factors, then where she lives, all these things to be taken into consideration and accordingly to be used. For example, patient is having in focal epilepsy and young female. So will you use sodium valproate as a drug? No, because why? Because it can have some teratogenic effects in if pregnancy is there. Along with that, it can have this hair loss and this other side effect profile of sodium valproate. So focal epilepsy, first drug used in those young female is levetiracetam, because levetiracetam have no teratogenicity and it's a very safe in pregnancy. So this is one of the things. If it is an absence seizures in a female, you don't have choice in those cases. You have to use sodium valproate. If it is not possible, then you can shift to lamotrigine in those cases where pregnancy is suspected, because lamotrigine is one of the safer molecules in pregnancy that can be given. Myclonics, definitely levetiracetam is the superior choice along with sodium valproate and topiramate. So this is another case. This is now what we have moved on from this focal epilepsy, what we have seen the first case, then generalized epilepsy, the absence seizures, what we have seen. Now we are going to move to another scenario of immune mediated things. So he is a 71-year-old man presented to an outside hospital with frequent brief tonic contractions of face and arm occurring independently on each side of the body several times per hour. A diagnosis of paroxysmal dyskinesia was made and he was treated with carbamazepine without success. He was admitted a few weeks later with behavioral changes and memory loss. The episodes of tonic contractions were thought to be consistent with fatiobrachial dystonic seizures, and EEG was performed during those episodes, revealed transient diffuse background attenuation followed by bilateral synchronous rhythmic delta waves. So this is a fatiobrachial dystonic seizures. So what I'm going to show you the video of this not this case, but another case was there, similar kind of thing. See the movement of the right upper limb. See. So this is a brachial seizure. Only one upper limb is there. If you remove his marks, there are some facial movements is also there. So these are typically fatiobrachial dystonic seizures. And what this entity is, antibody testing was positive for voltage-gated potassium channel complex antibodies, specifically leucine, which glioma inactivated one antibodies, that is LGI1. Brain MRI revealed bilateral hippocampal fluid attenuated recovery, hyperintensities, what as shown in the diagram, and seizures ceased after treatment with IU steroids and cyclophosphamide, but some memory impairment. So in those cases, the role of antiepileptics is limited. It is a more of a immune modulation that is what needed. Steroids, cyclophosphamide, rituximab, and there are various entities like LGI1 encephalitis nowadays. Since last 7 to 8 to 9 years, these entities are coming up in the clinical scenario, and these are very much treatable entities. So this case illustrates the importance of recognizing fatiobrachial dystonic seizures as the first manifestation of LGI1 encephalitis. Earlier recognition and treatment might have prevented the evolution to full-blown limbic encephalitis. So early treatment is the gimmick in each and every case. If you treat early, they will have this cognitive impairment and all these things will be lesser. If you late detection and late treatment, this can have significant cognitive impairment and other problems in the later life. So what are these the two categories of this paraneoplasty? These are entities called immune-mediated encephalitis. So there are two categories of these antibodies. One is antibodies to intracellular antigens, clinical and cancer association. These are different kind of antibodies. I'm not going to go into the details of the intracellular antigens. And this GAD65 that is present with this limbic encephalitis, then stiff person syndrome associated small cell lung cancer. Then there are various antibodies. I'm not going to talk about this. Antibodies to cell surface antigens or synaptic antigens. These are important because these are very much treatable. And one of the entity what we have seen is the LGI1. There is another entity called NMDA receptor encephalitis. We see the last but three from downside third. Psychosis, seizures, NMDA receptor encephalitis presents with psychosis, seizures, encephalopathy, orofacial dyskinesias, hypoventilation, and most common in young women, and is most commonly associated with ovarian teratoma. Why these entities are very important? Antibody discovered primary targeted intracellular antigens, that is ANA1 first slide which I have seen, and were associated classical paraneoplastic syndrome, that is limbic encephalitis, that had a very strong association with cancer and a poor prognosis. A second group of antibodies which we have seen are associated with cell surface or synaptic antigens, that is NMDA receptor, LGI1, responds better to immunotherapy and can occur as a paraneoplastic disorder in association with teratoma as an idiopathic autoimmune disease, or in other clinical settings, autoimmune encephalitis post-herpes simplex virus encephalitis. Post-herpes also we are seeing nowadays NMDA receptor encephalitis. So these are the associations which we should understand. These are not seizures. These are basically immune-mediated disorder, has to be treated more with immunomodulatory drugs. So this is just a few of the last of the slides. I'm going to talk about the herbs, because many a times we see that patients are taking some Ayurvedic medicine. Some of them might be taking some Kada, some Patanjali medicines, Shankapushpi, and all these things. So more than 50% of patients with epilepsy use herbs and dietary supplements, because initially they are in a denial mode. They don't think that it is, and there is very much social stigma attached to this epilepsy medicines. We should understand that these epilepsy medicines are not very hazardous to the body. They should understand they don't affect your kidneys and liver. They will not affect your day-to-day activities. So they should be emphasized in their minds initially only, so that they will have confidence in these medicines. If you don't, then assuredly they will definitely land up with these dietary supplements. So more than 50% will use herbs, this dietary supplement. This is data actually from one of the studies, and 29% of those do not report these exposures to their physicians. They will not tell you what they are taking. And after some time, when you ask, the seizures will not control, they are having something additional manifestation, they will tell you, this is I'm taking. So these are the, why I'm telling, because these drugs have a potential of lowering of seizure threshold. Asafoetida, that is hing, what we are seeing, borage used for fever and diuretic. All these things are having a potential of lowering of seizure threshold, and they will not be under control even with the anti-epileptic medicines. Ergots, eucalyptus oil, then which has been used in Jandumam and all these things. Then evening primrose oil, which is used in breast-related abnormalities and some menstrual-related abnormalities. Ginkgo biloba, ginseng, penny royal, used in abortion and menses. Sage, that is one of the, sage is a plant actually that is used for lipidemia, gastrointestinal symptoms. Shankapushpi, which is a very common Ayurvedic medicine in India. Star anise, star fruit, wormwood, yohimbine, all these drugs, they have a potential of lowering of seizure threshold. So we should ask in the history what they are taking along with this if they are not having well-controlled seizures. So because drug-drug interaction and lowering of seizure threshold, all these things happen with these herbs and some supplementary medicines. So take-home message is from what I've told is that first you have to understand whether it's a true seizure or a dissociative seizure. Dissociative seizures, what I'm told you, the points against the dissociative seizures and favoring toward dissociative seizures. Try to classify epilepsy into focal versus generalized, because this is the most important thing you should do at the onset of epilepsy only. Because if you are giving the wrong drug in a wrong epilepsy, the wrong drug in that kind of epilepsy, it will have a potential harmful side effect within those patients. Avoid sodium channel blockers in idiopathic generalized epilepsies. No two sodium channel blockers to be combined. For example, if you are giving phenytoin and carbamazepine, that will have a more side effect profile rather than any usefulness in those patients. So whenever you are using carbamazepine, use only carbamazepine. Whenever you are using oxcarbazepine, you only use oxcarbazepine. Never combine those two or phenytoin along with these other sodium channel blockers. Valproate in idiopathic generalized is the first choice to be used, because it is nowadays what we are saying is that if valproate is not responding in that generalized epilepsy is there, then if a valproate is not responding, then it will have it will have difficult control over the period of years. So valproate has to be the first drug to be used in idiopathic generalized epilepsies. Remember this newer antibody mediated diseases, which I have told you, where the anti-epileptic, this will have seizure-like manifestations, but these are more responding to immune modulated drugs rather than these routine anti-epileptic medications. So I'm just going to come again to the first one of the MCQ question. So which of the following seizure type is not seen in the generic generalized epilepsies? Again, absence seizures, generalized tonic-clonic seizures, myoclonic seizures, and focal aware seizures. So the answer is focal aware seizures, which is not seen in genetic generalized epilepsies. Absence is the most common, followed by generalized clonic-clonic, followed by myoclonic, and followed by generalized tonic-clonic. These are the three types of seizures being seen in genetic. Whenever myoclonus is the element seen in epilepsy, you should understand it is mostly seen with idiopathic generalized epilepsy. It is never seen with this focal or symptomatic epilepsies. And with this, I talk. And again, I thank IMA Nanded and Johnson & Johnson giving me the opportunity on this talk. I hope this will be helpful in your day-to-day practice of epilepsy. Thank you.
Thank you, Pramod sir. If anybody is having question, can raise their hands and participate in a direct question answer with him. There are some questions in the chat box or question answer. You can give a live answer.
For this, first question is focus on newer anti-epileptic drugs. See, actually, and newer anti-epileptic drugs nowadays marketing term is the breveracetam, then lacosamide. These are the two drugs which are really useful in focal epilepsy. But lacosamide has now a time-tested drug in the field. This is a newer sodium channel blocker with some different mechanism of action. In those focal epilepsies, lacosamide is one of the wonderful drugs to be used. But the problem with this PR interval prolongation and some AV blocks are there, they should be avoided. And this breveracetam, what I'm saying is this is just new molecule. This already the molecule was there, but the patent, because of this loss of over, now this has come with the multiple companies and the lesser cost. So we will see this more use of breveracetam, and it will be useful as because it is a sodium. It is a SV2A receptor blocker, and it is 10 times more active than levetiracetam as the literature, as the theoretical literature. And drug of choice of epilepsy in pregnancy, doses, precautions. Drug of choice for epilepsy in pregnancy, first drug is levetiracetam, followed by lamotrigine. Levetiracetam is now in Europe, this European Pregnancy Registry and another international pregnancy registry. Both these registries are saying levetiracetam is the safest molecule. If it is not controlled, lamotrigine can be used. Even oxcarbazepine, carbamazepine can be used, but with the lesser dosages, like less than 300 or less than 450 milligram per day, that can be used in those pregnancies. Then newer modality for diagnosis of focus of epilepsy. Newer modalities, then you have to use, first is whether it's a focal epilepsy, then 3 Tesla MRI is the best method to be used. In that, if you want to see the focal epilepsies more and more, then you should ask about the thin cuts or SPGR sequencing. In those cases, it is not easily to this, what I have shown in the case that focal cortical dysplasias are routinely missed on these MRIs, even 3 Tesla. So whenever you are suspecting focal epilepsy, you should talk with the radiologist first that I am suspecting this and this. So they will see more carefully, because radiologists are not well versed to see these focal cortical dysplasias. So in those cases, you should ask for this SPGR or thin cuts in those particular cases when you are suspecting a focal epilepsy. I think these were the questions that has been asked. Anything else? Prasad? Anything else to be there?
Sir, for the epilepsy point of view, the questions has been answered from your end.
Yeah.
There are few questions which is there for the migraine, where I request Dr. Devashish Ruikar sir as well as Bhede sir, you can also answer that questions.
Sure, sir. Hello. Yeah, actually there are a few questions related to migraine. So first of all, there was a question, how much is the migraine?
Dr. Devashish,
TIA, both. So basically, they say apart from other thing, it can be risk factor and with the odds ratio of 2. So the migraine itself can be acts as a risk factor for stroke and TIA both. But there are other risk factors, but they don't know exactly relationship, but the odds ratio they have found out, which is the odds ratio of 2. So definitely it's one of the risk factors, especially migraine with aura. Person having migraine with aura. And if the person having migraine with aura, they have got more T2 changes, some small changes on MRI also. In the answers, I have just given that JNNP reference as well. Firstly, the headache and migraine do coexist, no doubt about that. Rather, it is quite common, but initially we have to treat the hypertension as per the guidelines of the hypertension. So we have to make the BP in the range of 120/80 or so as per the standard guidelines. On top of that, the person, the question was whether migraine and hypertension coexist. So definitely they can coexist. For migraine to satisfy, again, the International Headache Society criteria is there. So the person should be having keep on recurring headaches, which are associated with photophobia and phonophobia. On an average, photophobia associated with 70%, phonophobia associated with 6%. Then they are associated with migraines. So in that situation, when the headache is well controlled, we can add the corresponding anti-migraine medications as per the standard protocols. And thirdly, the hypertension and migraine, how to treat basically as per the standard protocol. Hypertension, we will treat it like a hypertension. Migraine, we will find out. Migraine, we will find out the comorbidities. There, if there is a young chap who has got little bit tachycardia, we can add propranolol. If he is anxious, we can add propranolol. If there is no asthma, we can add propranolol. If is hypertension, but still there is a lean thin person who has got frequent headaches, we can add flunarizine. Will for the hypertension, the triptans are, though there are trials of the safety of triptans in the migraine with hypertension. So there are most of the time the triptans are little bit to be taken cautiously with the person having hypertension and IHD, because in some of the trials triptan has shown to cause vasospasms, can cause precipitation of the ischemia of coronary or peripheral vascular disease, though they are safe than ergots. But there are some trials, there are some reports, there are some safety reports which have proven their safety in hypertension. There are some reports which are proven their little bit. Next question was flunarizine safe in patient with hypertension and CKD. Okay, so there is a large trial which was published in BMJ 3 years back, say 2017. So in that trial, they have reported 48% of the CKD patient will get migraine. 40 is reasonably long number. So say half of the CKD patient can get classical migraine as per the standard criteria. And in that situation, we have to control the BP and treat the migraine as per the standard guidelines. Flunarizine has got 95% renal, the hepatic metabolism. So it is reasonably for the renal. say you can start with 5 milligram and you can use for 10 milligram, and that too little cautiously. So we can use. We have to control the CKD with the standard parameters, control the hypertension, and if migraine criteria is satisfied as on the CKD, we can use it safely. But and again, propranolol or metoprolol can be used there. So after how many days of we should escalate the prophylactic dose of migraine? Generally, it will depend on the person to person. If we address the comorbidity properly, if the person's triggers are managed possibly, or can say if for 1.5 there are some online migraine diaries are available. There are apps are available. If the person is keep on saying there is absolute no use, after 1.5 to 2 months, possibly, we can think of changing the drug, or after 1 month, we can think of escalating the drugs. So after how many days that has been done? Okay, then there is a question. Which drug should we prefer in the first line of treatment in migraine, propranolol or flunarizine? These category 8 drugs we have seen, divalproate, flunarizine, topiramate, and propranolol. All are category 8 drugs. Either one of them can be chosen. All are available in our basket. Choose either of them. Either of them are okay, no doubt about that. So that's fine. So, and that's all about the questions regarding migraine. And the last was drug of choice for epilepsy and pregnancy. I think Dr. Pramod sir has already answered it live, especially the levetiracetam is the first choice. So that's all from my side. Thank you.
Thank you, Devashish sir, for such a nice talk, and for the answering the question of all the attendees who are very curiously asking the question about neurology, which is a very good thing that the people are taking more and more interest in the super specialty knowledge also. And thank you for attending once again from Nanded IMA. I am very much thankful to you for answering this.
Thank you so very much.
Again, I request all the participants who are there that you should be registered through the DigiShield. If you are not registered through DigiShield or directly you are joined, then you have to give your email on the Dr. Suresh Kadam 123. I'll write in the chat box, or the mobile number I have given. You have to screenshot the payment given to IMA Nanded and your registration number and full name. Write the full name on the attendees report card, which is seen on our screen, because we will be able to identify everybody, and we will be able to give certificate to everybody. Now, one our speaker was remaining, is remaining, Dr. Vidyadhar Bhede, who is busy. After this, some lectures, we can have his question answers also. And I request all the attendees that we will meet at right 12:45 for the next session of this, which is having low bracket as a surgeon and one diabetologist who will be giving his lecture. And everybody should attend the second half also. This time is allotted to you for the lunch break, and kindly rejoin as the observers from MMC are observing this attendance. Thank you. Good day. You can join at 12:40 also. Okay. Thank you, sir. Or you remain joined, and then again you can switch over to this CM class webinar.
Thank you, sir. Thanks a lot.
Yes, we can start the second session of our Meet the Masters from IMA Nanded. And now the next presenter panelist is Dr. Raghavendra Chalikwar, who is a leading neurosurgeon from Nanded, who has studied from a reputed institute from Bangalore and doing various complicated surgery of spines and brain surgeries he had done, and he has presented many more complicated cases and recovered many more trauma cases in Nanded and malignancy cases he has operated successfully. He is working in Apeksha Hospital, Nanded since last 5 to 7 years. He is a successful practitioner and a good orator and good teacher. Now I hand over my this one mic to Dr. Raghavendra Chalikwar sir for his wonderful presentation. Raghavendra sir, unmute yourself. Unmute, sir.
Audible?
Yes. Yes, you can start.
Dr. Raghavendra sir?
You are audible, sir.
Yeah. My screen is.
Yes, sir.
Yes, sir.
It is visualized, sir.
Yeah, thank you. I'll start the presentation now. First of all, good afternoon all. I know this after lunch break there will be a slight dizziness, so I will try to simplify the things. I'll be talking about the low back pain management. Initially, I review the low back pain. What's this? This is a very common problem. If you see the epidemiology, 60 to 90% of adults experience back pain at some point in their life. It increases with incidence in the age group of 35 to 55 years. 90% of them resolve in the 6 weeks, and 7% patients become in male and females both equally affected. 85% of them never given precise pathognomical diagnosis as as this is most of the time the cause will be low for the low back pain will be strain, so there won't be any pathogonoanatomical differentiation. This low back pain is the fifth leading reason for medical office visits, and it is also a first most cause and the first most cost of work related disability. If you before going to the low back pain management, I'll try to simplify the things by informing the spine module. Our spine usually gives our body stability and mobility. There are 33 bony vertebrae stacked on one above the above, from the cervical spine to coccyx. Between each vertebra, there are the spongy discs of cartilage that cushion the vertebrae. Ligaments surround the spine, which supported again by the muscles. Each vertebra aligned to contain the spinal cord, safe and workable. Major nerves pass through the spaces in the vertebrae to connect the spinal cord and other parts of the body. Those foraminers are called as vertebral foraminers. Low back pain is the area most commonly affected by the pain and injury. And this, in medical language, you can call it as a lumbar region. Your lumbar spine is at work when you bend, stoop, sit, and lift. Improper bending, stooping, sitting, lifting can cause you neck, shoulder, back. Possibly even more serious injuries can be caused with the abnormal postures. Learning the proper way to perform these activities will help you minimize the risk of pain and injury. Our goals and objectives of the talk will be evaluation and differential diagnosis of the low back pain, and discuss when to obtain imaging, and then discuss the selected etiology, that those are the most common patients are getting suffered, and then the different modality discussion. most of the back pain caused by a number of things, such as overuse, strain, or injury, and multiple other causes that will be discussed in the further slides. Most of the time, low back pain is not related to a disease or injury. Rather, it is caused by inability of back muscles, ligaments, and joints to work as they should. There are three types of low back pain in terms of duration of affection. Acute low back pain comes on suddenly and typically lasts less than 6 months. And there are other type. The second type is recurrent low back pain, which occurs with frequent episodes of acute low back pain. Chronic low back pain typically lasts for longer than 3 months. If we go through the etiological point of view, low back pain can be classified into mechanical, non-mechanical, and visceral. And these are the multiple causes of mechanical low back pain or leg pain etiologies. These are usually attributable to musculoligamentous injuries or age-related degenerative disease in the intervertebral disc and facet joints. Lumbar strain is the most common etiology of mechanical low back pain. Degenerative disc facet is the second most common cause of mechanical low back pain. Then comes herniated disc, spinal stenosis, osteoporotic compression fractures, spondylolisthesis, traumatic fractures, congenital disease, kyphosis, scoliosis, transitional vertebrae, spondylosis, internal disruption, and resumed instability of lumbar spine. Then low back pain etiologies. These are usually caused by the inflammatory, infectious problems of our systemic disease affecting the vertebral musculoskeletal structures. Among the causes of non-mechanical low back pain, first comes the neoplasia. That may be because of multiple myeloma, metastatic carcinoma, lymphoma, leukemia. Then comes the spinal cord tumors like ependymomas, meningiomas, cyst, then neurofibromas or primary vertebral tumors. Then comes the infection, which includes osteomyelitis, septic discitis, and paraspinal epidural abscess. The non-mechanical low back pain can be caused by the skin infections also. These are shingles. Then comes the inflammatory arthritis, ankylosing spondylitis, psoriatic spondylitis, Rett syndrome, and inflammatory bowel disease. Among the visceral disease, the low back pain, diseases of the pelvic organs that can be prostatitis, endometriosis, chronic pelvic inflammatory disease, renal disease, nephrolithiasis, pyelonephritis, pyelonephric abscess, aortic aneurysm, gastrointestinal disease, pancreatitis, cholecystitis, penetrating ulcers. These patients may have low back pain because of radiating pain that originates because of viscera but radiates to the low back region to present as a low back pain. These are the diagram is showing the common pathognal-anatomical condition of the lumbar spine. The most common etiology here is herniated disc. If you see the most of the surgical patients, those gets operated. These are because of these most common lesions. First is the herniated nucleus pulposus. This is a nucleus pulposus which herniates through the annulus, fibrosis, and compromise the foramen as well as spinal canal. Then comes the spinal stenosis, which is secondary due to hypertrophy of the facets and thickened ligamentum flavum. Among the more rarer etiologies, the spondylolysis and spondylolisthesis. Lysis is the breakage of the pars interarticularis, and listhesis is the of one vertebra from the other vertebra. In the diagram, you can see the L5 has the listhesis that is displaced anteriorly than the sacrum, disturbing the curvature and causing back pain. Before going ahead with the evaluation of low back pain, we should ask important questions to ourselves. Is the systemic disease is the cause of low back pain? Is there social or psychological distress that prolongs or amplifies the symptoms? Or is there a neurologic compromise that requires surgical intervention? To answer these important questions, we should have a careful history and physical examination. If necessary, imaging and labs whenever indicated. Acute low back pain, usually they have a acute onset of a presentation. We should ask time course of onset with associated activity time of the day. That means when was the first symptoms occurred. Then comes the pain. The pain, that is where it is located, site, and how it radiates from the original site. Then comes the nature, whether it is sharp, throbbing, or dull. Then we should ask the severity, then aggravating and relieving factors. Then we should ask the prior injuries to rule out the post-traumatic low back pain. Then other associated complaints for the low back pain. Examination of the low back should start with as the patient walks in your cabin. Then heel and toe walking. Skin examination should not be excluded because it can have findings like a zoster, capsular spots, which can give you further clues to the further diagnosis. Then you may notice the hair tufts over the lower lumbar region and abnormal spinal curvature, that is scoliosis, kyphosis. Physical examination should focus on the neurological point of view. Palpate all the spinal process of the thoracolumbar spine. Neurological examination should include the muscle strength and reflex testing. Then we should do the straight leg rising test, bowstring sign, distracted straight legs test, which comes positive with tripod sign or flip sign. Then comes the femoral stretch test, anal wink, and we should never forget the peripheral pulses, because many of the times whenever the patient comes with the claudication, those can be vasculogenic or neurogenic. This peripheral pulses examination gives you the differentiating point in the vasculogenic claudication or neurogenic claudication. Then comes we'll come by one management of mechanical low back pain according to the cause. If we in mechanical low back pain in herniated disc, this is the most common presentation in OPD. They usually occurs in the age group of 30 to 55 years, and they are associated with sciatica, that is radiating pain, or leg numbness, paresthesia. These are a highly sensitive and specific finding for herniated disc, and they will have an exaggeration of pain which occur on coughing, sneezing, or Valsalva manoeuvres. In spinal stenosis, patient usually presents in older age group, and they have a neurogenic claudication with addition of radiating back pain in the lower extremities and lower extremity numbness, which exaggerates by walking and spinal extension, and improved by sitting. This is in toto diagram to show the differential diagnosis of the low back pain, in which you can see the mechanical low back pain, causes of mechanical low back pain, causes of non-mechanical low back pain, and causes of low back pain. In older adults, there should be some suspicious, which older patients should we evaluate for further patients needs further evaluation and treatment. This in older age, the probability change as the causes change in the older adults patients, because most of the patients, they have a comorbidities, like they may have a past history of cancer or compression fractures, spinal stenosis, aortic aneurysm, osteoporotic fractures without trauma in older adults, because they have a trivial trauma, like they will tell that they have just sat and the pain started. That is then you should think of osteoporotic fractures. Then spinal stenosis, secondary to degenerative processes and spondylolisthesis. Degenerative process, which involves the hypertrophy of ligamentum flavum and hypertrophy of facet joints, that leads to canal stenosis, presenting as causing canal stenosis and foraminal stenosis, presenting as a low back pain with radiating pain and claudication. In such older age groups, early radiography is always recommended. Which patient should be given more attendance and which should be more evaluated? Those serious illnesses we should find out in the history and examination. Whenever the patient is having systemic, inflammatory or infectious problem, we should evaluate further. If the patient is having major trauma or mechanical injury, we should again evaluate to rule out possible fractures. If patient is having long term of corticosteroid use, then the patient is at greater risk for osteoporotic fractures. If the patient's age is more than 50 years, then there is higher incidence of malignancy and osteoporotic fracture. If the patient is having unexplained weight loss or fever, immunosuppression, immunodeficiency, injection or drug abuse, or any past active infection, in such cases, those patients should be given priority and further evaluated. In the clinical assessment, we should ask ourselves if there is any neurological compromise in form of sudden anesthesia or bowel bladder incontinence that may suggest cauda equina in lumbar region. Then we should ask the severity of the discomfort that patient is suffering from. Then the progressive neurological deficit that leads to possible cauda equina syndrome and severe nerve root compression. In clinical assessment, we should again stress for psychosocial factors, because these are the complicating psychosocial factors that may impede our treatment and prolong pain and predict poor outcomes. Patient will have a history of failed treatment in the past. Patient may be suffering from depression or somatization. Patient may be having a substance abuse, job dissatisfaction, ongoing litigation or compensation claims. Such factors also impede our treatment protocols. This is an acute emergency in low back pain, cauda equina syndrome. The patient will be having low back pain, which is acute or chronic radiating pain with acute worsening. There may be unilateral or bilateral lower extremity motor or sensory abnormality. Bladder or bladder dysfunction will be there. They're usually associated with perianal anesthesia, that is saddle anesthesia. There may be a bladder dysfunction or impaired emptying, difficulty starting or stopping the stream of urine, or may present as a incontinence due to overflow. There are clinical assessment, categorize the acute low back pain patients into 3 categories. First is a symptom of potentially serious spinal conditions like tumor, infection, or fracture. Second category is sciatica or neurogenic claudication, discomfort, that is discomfort radiating to the legs. Then non-specific back symptoms. This is the most common strain of soft tissue element, and this is the most common diagnosis in your daily OPD cases. So in low back pain, when should we use the radiology? If the age is more than 50 years and a patient is not improving, and there is even after 4 to 6 weeks of conservative therapy, if there is recent significant trauma, if patient is having neurogenic deficit, if patient is having systemic symptoms, fever, unexplained weight loss, or patient had a history of cancer, substance abuse, chronic corticosteroid use, or if there is a suspicious of ankylosing spondylitis. 3 different kinds of imaging can be used in evaluation of low back pain. First is plain radiography, then CT and MRI, which are more sensitive for soft tissue as well as bony abnormalities. First is a X-ray. Plain films are very rarely helpful in the diagnosis. If the patient is having trauma and having fracture, then X-ray will give you the definitive diagnosis. If patient is having prolonged corticosteroid use, that may cause osteoporosis, and if the patient is having more than 70 years age, then we should have a baseline X-ray to rule out possible fractures. Or on clinical examination, if you're suspecting abnormal curvature of spine, we should get a baseline X-ray. Then comes the MRI, which is the never an emergency to get an MRI if only an exclusion is quad equina syndrome. If the patient's presentation is like a quad equina syndrome, we should get an immediate MRI that shows you the tumors as well as soft tissue changes better than the CT scan. So when will be the CT scan will be indicated? Whenever if you are suspecting fractures, you should advise a CT scan. That gives you a clear pictures about the bony problems. Sagittal reconstruction is mandatory in CT scans. Soft tissues like disc and spinal cord are poorly visualized. But if we're doing CT myelogram, in addition to plain CT, that adds contrast in the CSF and shows the spinal cord as well as nerves contour better, but not equivalent to the MRI. Labs are rarely necessary in evaluation of low back pain, but baseline CBC, ESR, PSA, alkaline phosphatase. This PSA and alkaline phosphatase, if you are suspecting as a cancer, then only you can ask for the lab investigation. If you are suspecting some kind of arthritis, then other baseline investigations like RA factor and HLA B27 can be asked for. Now coming to the treatment of low back pain. First, we'll consider the non-specific low back pain. That is, in evaluation, if you found that patient is having non-specific low back pain, we should prescribe NSAIDs and muscle relaxant for symptomatic relief. Sedation from relaxant may reduce the utility, but bed rest is not effective in non-specific low back pain cases. Parasites are not effective. Electrostimulations are not effective in non-specific low back pain. Now coming to the acute low back pain with other causes. Then like prolapse intervertebral disc or spinal stenosis, those in the mild cases. In those cases, we can try for hot fomentation and NSAIDs, narcotics only and only if a patient is suffering from severe pain, and that will be for short duration. Neuromodulators like gabapentin and pregabalin can be used. Muscle relaxants like baclofen, benzodiazepine, cloxazole, cyclobenzazine, dantrolene, metaxolone, tolperisone. These can be considered in management of acute low back pain. These patients usually responds within a period of 4 to 6 weeks. Then again reevaluate treatment after 4 weeks. 90% of the patient gets better within 4 weeks. Then we can ask for physical therapy or physiotherapy. If the patient is having persistent low back pain, then we should see for the poor compliance. That is, if the patient is not ready for the intensive exercises, then additional medications can be asked for, and other causes should be ruled out in persistent low back pain cases. Treatment with the concomitant mental illness, if present, should be treated simultaneously. Patient education about low back pain is very much important to have a long-term good prognosis. In persistent low back pain cases, we can also consider for root blocks as well as epidural injection, or combination of multimodality treatment can be offered for such cases. What are the indications for surgery in low back pain cases? The primary indications are severe or increasing neurological deficit. That means patient is having persistent symptoms. Those are not controlled, not getting controlled with conservative therapy and manual physiotherapy. In such cases, we should ask for further evaluation, and if there is a clinical radiological evidence for the pathology indicated that may be prolapse intervertebral disc or spinal canal stenosis. In such cases, we should advise surgery. In cases of increasing neurological deficit, if the patients who are put on conservative treatment, if they are developing neurological deficit, then we should reconsider the patient, and we can suggest if we can suggest the surgery if there is a clinico-radiological correlation. That means if the pathology is at L5 level and deficit is correlating, then we should advise surgery. In quad equina syndrome, that is an emergency. You should take decisions within 24 hours to have a better outcome. If the neurological deficit, that means mild, in example, we can give as a, if patient is having a mild toe extensor weakness, then in such cases, we can ask for conservative therapy also, but we should inform first on the hand that that may worsen before taking decision of non-invasive therapy. In cases, in elective cases, we should always rule out the spinal instability with X-ray flexion and extension to have a good outcome after the surgery. If patient is having spondylolisthesis, we should offer them surgery, because in such cases there will be always instability and patient will have persistent symptoms. To have a better quality of life, surgery will be advised in such cases. And non-responsive spinal stenosis symptoms. In such cases also, surgery is indicated. Again, if the patient is not having any neurodeficit, but having on and off severe persistent pain and sciatica for more than 1 year, those patients also can be considered for elective surgery. What are the different types of surgeries that can be offered to the patients? It depends on the pathology. If the pathology is prolapse intervertebral disc, then discectomy can be offered to the patient. What types of discectomy we do have now? We have laser discectomy, endoscopic discectomy, microscopic discectomy, then at last open. Then comes the laminectomy and decompression for spinal stenosis cases. Then comes the spinal fusion procedure, that is PLIF, TLIF, then other surgeries which are offered for spondylolysis and spondylolisthesis cases. Then depending on the pathology, other surgeries can be offered to the patient, which includes excision of ependymomas, meningiomas, arachnoid cyst, neurofibromas, and metastasis. In metastasis cases, if the single level or maximum 3 levels, and if the quality of life and survival is going to improve more than 3 months, then you should offer surgeries in metastasis cases also. But that depends on the primary cancer. What are the other modalities of low back pain treatment? Traction, massage therapy, acupuncture, Ayurvedic. I didn't get any large RCTs or large trials to suggest their much usefulness in acute low back pain cases, but patients are preferring surgical management. They'll try for traction, massage, acupuncture, Ayurvedic, but at some time they will turn back and then they'll ask for surgery. Before concluding, I'll just want to give us some points for prevention of low back pain. With maintaining regular physical fitness regimen, that will be helpful in preventing injury to your low back, and participating in regular strengthening exercises can also help you to give strength and flexibility of your back, core, and leg muscles. If you sit for a long time, remember to take frequent breaks every 20 minutes so that there will be stretching and strengthening of your lumbar back muscles. Also, while using proper body mechanics, while at work, play, and performing your daily activities, that will help you prevent from the low back pain. Weight reduction, smoking cessation, and improvement of strenuous and stressful working condition, that also helps in the prevention of low back pain. Back braces are ineffective in prevention. Thank you all. Stay safe, stay healthy, and get vaccinated.
Thank you, Raghavendra sir, for your such knowledgeable and good explained lecture from you. This has enlightened the knowledge about the low back pain in the minds of all the participants and attendees. And I thank you sincerely from the base of heart from the IMA Nanded for giving time to us and participating as a panelist in our this webinar. Friends, after this, we are having a next session of neurophysician, Dr. Babaro Darku. And sir, your hand, any time for a question answer?
Yeah, I can wait, sir.
You can wait for some time?
Yeah, 10 minutes I can wait. I have
Okay.
call, I have to go, sir.
If anybody has any question, there are question in question answer box, so you can visualize and see. Is there any question for you in this? Spinal disease. Is there any prophylactic test? There are questions from Gajanan Dharmure.
Yeah, are there any prophylactic tests or investigation to know spinal disease in advance in a symptomatic patient? Yeah, it is difficult to tell if the patient is having symptoms, then only one evaluate. Otherwise, there are no prophylactic tests because getting an MRI or CT beforehand to have a look for any disease that is not indicated in trials. So they have not suggested to have an CT or MRI.
Any other questions from the attendees? Sir Shilpa Palevan, when you say the treatment for 4 weeks are NSAID to be prescribed for?
NSAID I usually prescribe for 3 days, and after that, whenever indicated. If the patient symptoms persist, then only it should be prolonged, otherwise not. Neuromodulators better help than the NSAIDs for prevention of recurrent attacks.
Sir, this is a Vivek Karad asking for how long we advise medicine and what are the side effects? Is the long-term use harmful? Vivek Karad, sir. Raghavendra, sir.
Yes, sir. Yes, sir.
How long?
Side effects are there because the dependency is the most common side effect for such drugs like gabapentin and pregabalin. If you taper also, they will come to know that no, something is different, and now doctor has changed the medicines. So dependency is the first factors, and second is I usually advise 4 to 6 weeks of pregabalin, full dose of pregabalin, then tapering doses and shifting to manual physiotherapy.
Is there role of any alternate cold and hot therapy for low back pain? The Shailendra Yadav.
In acute pain cases, hot therapy I usually prefer, but there are trials that suggest that alternate cold and hot therapy also helps, but not RCTs are not there, so I won't prescribe for the alternate cold and hot therapy.
This is a long question from Nitya Raj Gopal. I have got patient who have done round of consultant including neurologist, orthopedic, physiotherapy, also psychiatrist. She has gone more investigation than necessary and nothing serious was found. She is on tricyclic antidepressant, gabapentin, muscle relaxant, calcium, B complex plus antihypertensive, all these things. It is very frustrating to see such patient. How can a GP help such patient? They feel that we would have something better to relieve the pain.
Dr. Nityaji, I'll first suggest that better to reassess the patient to have any localizing pathology over there. If not localizing, assess the psychiatric evaluation. If that is also not the point of concern, then stop all the medicines, then reassess again after 2 weeks.
Samir More, how severe should be sciatic pain to be advised for surgery?
If the patient is not able to move at all, and there is a clinico-radiological correlations. That means if the radiating pain, if the patient is having L5 or L4 level, that lesion pathology should be correlating with the presenting symptoms. If there is a correlation between radiology as well as presentation, then only you should consider for surgery. When if the patients are not getting comfortable with conservative treatment. But in surgeries, when it is indicated, if the patient is having spondylolisthesis like grade 3, grade 4, directly go for surgery. If canal stenosis less than 4 mm, directly go for surgery. Don't wait. If patient is having lysis, go for surgery.
Samirti, what is the success rate for the spine surgery is mainly in the disc prolapse?
90% of the patients do better. In 90 patients, 60% will have go for off medicines. 30% patients will have some medication and physiotherapy dependence. There is a recurrence rate of 5 to 10% in microscopic as well as endoscopic surgeries.
Kirti B says, sir, in ankle spondylitis, which is the best symptom improving drug according to your experience? Ankylosing spondylitis. IMA.
Pain will respond.
Yeah.
Pain will respond to medicines, but rest of the like stiffness and inability to have a flexible life, that won't respond on medications.
The next, our presenter is ready. Other question and answer will be answered by our Dr. Raghavendra on online live. He will answer. Your questions are welcome. Everybody is enthusiastically taking part in post-lunch session. This is very good thing. Now I introduce Dr. Bavarao Darku sir, who is a Bhumiputra of Nanded and Maharashtra and Andhra border, who is directly coming from a farmer family and establishing himself in a city of Nanded as a neurophysician. He is the first generation of a farmer family. After doing his some work as a MD medicine in Nanded, he has gone for DM and now successfully he is giving his services in the Life Care Hospital in Nanded as one of the leading neurophysician, and IMA Nanded is proud of him and his work. Now I switch over to Dr. Babarao Darku for his informative lecture. Sir, Darku sir, please.
Thank you, Kadam sir, for a nice introduction. Thank you, IMA Nanded, Dr. Kadam sir, for giving me this opportunity to speak on approach to the diagnosis and management of vertigo. Am I audible? Am I audible, sir?
Yes, sir, you are audible and you are visible also.
So my topic is approach to the diagnosis and management of vertigo. During next 30 to 40 minutes, I will be taking you on how to approach a patient with vertigo, how to make the differential diagnosis and investigative approach. Coming to the introduction, as you know, vertigo is one of the most common health problem in adults, and almost 40% of the patients in United States present with dizziness at least once during their lifetime. And during OPD also, we see many patients coming with the vertigo, and it is major health issue in elderly patients because vertigo leads to falls in elderly and fractures. And one of the important thing is that vertigo has got the treatment. It is potentially amenable to the treatment. So we must know about how to evaluate the patients with vertigo properly. So diagnosis of vertigo is often difficult for even physicians, maybe for neurologists also, because of complexity of equilibrium system, lack of shared vocabulary. Means many patients, they have different presentation as vertigo. Their proper description of vertigo is not proper. So analysis of the symptom is very important. And there are numerous causes of vertigo. And we see many patients going to the all specialty. Many patients with vertigo, they go to the all specialties. They go to neurologists, ENT specialists, medicines, ophthalmology, psychiatrists. So all of us see vertigo patients in day-to-day our OPD practice. So it is must that we should know how to manage and evaluate the vertigo patients. Because if we miss the dangerous vertigo, then it can be potentially fatal to the patient. So we know how our balance and posture is maintained. There are three systems which helps in maintaining our posture and balance, like vision, vestibular system, and proprioceptive system. These three systems helps to maintain our posture and balance. So impairment of any one of these functions, vision, vestibular system, or proprioception means from the nerves or skin, can lead to dizziness. A patient has impairment in one of the system can lead to mild dizziness. A patient has impairment in more than two or more of this system, then it can lead to severe dizziness. But today I will be talking more on the vestibular system and its connections, because vestibular system is responsible for predominantly vertigo. So when patient comes to the OPD with vertigo, patient says, "Doctor, I have a chakkar, dizziness." Patient म्हणतो की मला चक्कर येते. So first thing, whenever patient comes with the chakkar or giddiness, we should ask the patient what exactly chakkar means. Listen to him and let him describe what the exactly chakkar or vertigo means. पेशंटला आपण त्यांच्या लँग्वेज मध्ये विचारलं पाहिजे की तुम्हाला नेमकं चक्कर म्हणजे काय होते. Without leading question, you should analyze his patient symptoms. Because dizziness is a gender term, it indicates that abnormal sensation relating to the perception of body's relation to the space. It is a non-specific term which includes variety of symptoms. Dizziness includes true vertigo, pre-syncope, and disequilibrium. So in one of the oldest paper in 1972, Dutchman and Hart, they described this dizziness into 4 categories. In this paper, they describe dizziness into the 4 categories as vertigo, lightheadedness, disequilibrium, and other dizziness. If patient says that I might faint, I am losing consciousness, or I might fall down, then it is syncope or pre-syncope, and it is usually associated with visual blurring or some warpness of extremities and seen in cardiovascular condition like orthostatic hypotension and cardiac arrhythmias. If patient says I might fall or I am losing balance while walking, then it is disequilibrium. Disequilibrium is seen in non-vestibular neurological disorders like cerebellar disorders or multiple sensory deficit. Multiple sensory deficit means like patient having peripheral neuropathy, vision problem, then he will have disequilibrium. So it is not a true vertigo. He is just losing the balance. So it is called disequilibrium. So which is non-vestibular origin. So many patients with diabetes, peripheral neuropathy, and vision, cataract, they come with the imbalance while walking. So generally they have, what they have is the disequilibrium. They don't have the vertigo. So if patient comes with the complaint of, that is false sensation of rotation, he says that he is rotating or surrounding is rotating, then it is true vertigo. And it is due to vestibular disorder, which can be peripheral or central origin. So today I will be talking more on the vertigo management and approach. And if patient says he is just dizzy, he feels that there is some lightheadedness, some heaviness in the head, and all the time throughout the day there will be some sleep problem, there will be some features of depression. So most of these patients are psychiatric patients, they are having anxiety and depression. So most common presentation of dizziness is vertigo. Around 45 to 55% of the patient, they present with the vertigo to our OPD clinics. So how do we approach a patient with vertigo? Most important is we have to characterize the symptom. As I told you, we have to analyze the symptom, whether it is true vertigo or non-vertiginous dizziness like pre-syncope, lightheadedness. Then after that, we have to characterize that vertigo. If it is true vertigo, then we have to characterize what it is. Is it a acute vertigo? Is it an episodic vertigo? It is coming episodically, or if it is a chronic vertigo. It helps to differentiate the making the differential diagnosis of vertigo. Then you have to identify the triggers. Does the vertigo coming with any particular position? If patient says he has vertigo in supine position or turning in the bed, then it is probably BPPV. If patient has vertigo or dizziness predominantly from supine to standing position or sitting to standing position, probably we are dealing with the orthostatic hypotension. If patient is on multiple antihypertensive drugs and if patient has decreased oral intake, they come with this kind of symptoms. And some triggers like just simple head shaking can induce the vertigo in patient with vestibular paroxysmia. Then fourth symptom, we have to ask the associated symptom. What are the associated symptoms with the vertigo? Does the patient have headache, photophobia, phonophobia? Then if it is there, then probably we are dealing with the vestibular migraine. If patient has neurological symptoms like diplopia, dysarthria, paresthesia in the limbs, then we are probably dealing with the stroke. If patient has only unsteadiness while walking and tingling, we are dealing with the peripheral neuropathy. If patient has Ear symptoms like fullness in the ear, tinnitus, or deafness, then we are probably dealing with the Meniere's disease. So in most patients with vertigo, successful diagnosis can be made only by history and examination. We don't need investigations, MRI in most patients with vertigo because it is clinical diagnosis and diagnosis by history. But many times acute vertigo is anxiety provoking for physicians and patients. So history is very important. In history, once you have to confirm that it is true vertigo. If it is true vertigo, then we have to ask, is it first ever attack of vertigo or long lasting recurrent vertigo? If it is a first attack of prolonged vertigo, then probably we are dealing with the dangerous vertigo like stroke. If patient has recurrent prolonged vertigo, then probably we are dealing with recurrent vertigos like benign positional vertigo, vestibular migraine, or Meniere's disease. Then second important history is duration of symptoms. Any patient coming to the OPD with vertigo, they says, I have a chakkar which lasted. If you ask how long it lasted, they describe whole attack. They says hours, half an hour, 1 hour. They describe the actually attack for, they take attack as a duration of symptoms. So we should particularly ask the patient how long that rotatory sensation was present. If you ask that, then only they will tell the exact duration of vertigo. If patient has vertigo lasting for few seconds, like less than a minute, it is BPPV. If patient has vertigo lasting for 90 seconds to 20 minutes, it is seen in TIA and migraine. If patient has vertigo lasting for 20 minutes to 24 hours, it is seen in Meniere's disease. If patient has vertigo lasting more than 24 hours, then it is commonly seen in vestibular neuritis and stroke, post-stage circulation stroke. So patient has chronic unsteadiness. Some patients come with a chronic unsteadiness since months. They have generally bilateral vestibular failure. These are elderly people with auditory problems and bilateral vestibular failure. And some patient with chronic cerebral degeneration, neurological disorder can have chronic unsteadiness like Parkinsonism or other neurological disorders. So third thing we should ask, does that vertigo comes with a position change? If it is positional vertigo, then it is benign positional vertigo, vestibular migraine, or vestibular paroxysmia. If vertigo coming spontaneously without position change, then we are probably dealing with the vestibular migraine, vestibular neuritis, or posterior circulation stroke. Already I told you associated symptoms helps in differential diagnosis. If patient has vertigo at rest, then again diagnosis is vestibular migraine, vestibular neuritis, and posterior circulation stroke. If patient has dizziness only while walking, then we are dealing with a chronic vestibulopathy. Any patient presenting to the OPD or casualty with acute new onset vertigo, first thing we have to see whether it is spontaneous or triggered. If it is spontaneous vertigo, then and continuous lasting for more than 24 hours, first thing we should look for is either it is vertebrovascular stroke or vestibular neuritis. And if it is coming episodically and lasting for less than 24 hours, then probably we are dealing with the vestibular migraine or Meniere's disease. If it is a triggered vertigo acute onset but continuous, can be drug induced, anti-epileptic drugs or other drugs. And if it is coming episodically but triggered, then and lasting for few seconds or minutes, then BPPV. Second most important tool for diagnosis is clinical examination. So clinical examination is important to differentiate between central and peripheral type of vertigo, and eye signs are very important for differentiating between central and peripheral vertigo. So in patient presenting with vertigo, we should look for eye signs. What are the eye signs we should look for? Spontaneous nystagmus. We should look for spontaneous nystagmus in primary gaze and eccentric gaze. Nystagmus helps to differentiate whether we have to look for whether it is primary peripheral nystagmus or central nystagmus. And then we should look for Dick-Salpike test and test for vestibular hypofunction or vestibular dysfunction, that is head impulse test. So if patient comes with a vertigo and on examination, if he has a spontaneous nystagmus, then you will look for the character of the nystagmus. If patient has vertigo, there is no spontaneous nystagmus on examination, then you should do Dick-Salpike test, whether it is BPPV. BPPV is diagnosed by Dick-Salpike test. If patient has vertigo and symptoms of vertigo and examination, if you see the nystagmus, then it is BPPV. So now how to differentiate between central and peripheral nystagmus? The spontaneous nystagmus of peripheral origin, it is due to the dysfunction of eighth craniola or labyrinth. It is mixed, it has got mixed and torsional components. And this peripheral nystagmus get suppressed with the fixation. If you ask the patient to look straight or fixed to the object, the nystagmus gets suppressed, and it gets exacerbated if you remove the fixation by French's glass, or if you look towards eyes with ophthalmoscope, then nystagmus get exacerbated. And intensity of the nystagmus, the nystagmus intensifies on looking towards the fast phase of nystagmus. In the direction of fast phase, it becomes more, and it is direction fixed. Peripheral nystagmus always direction fixed. It beats only in one direction. So, whereas this is the, I will show you the example of peripheral nystagmus. Here you can see that there is nystagmus is beating towards the left. The right side on looking towards left, nystagmus has got, on looking towards left, nystagmus has got fast component, and fast phase of nystagmus is towards left side. On looking to the right side, the intensity of nystagmus decreases. So it is unilateral left beating nystagmus, which is of peripheral origin. Whereas central nystagmus is seen in lesions of brainstem and cerebellum. Central nystagmus, here torsional component is torsional. It can be torsional, horizontal, or vertical, but it is purely torsional, purely vertical, and purely torsional. There won't be mixed component like horizontal torsional or vertical torsional. And it is not fixed by suppression. If patient looks straight also, they will have same intensity of nystagmus. And intensity of nystagmus doesn't change with the looking in various direction. It remains same looking on either direction. And it's a direction changing nystagmus. If you ask the patient to look on left side, nystagmus becomes left beating nystagmus. If you ask the patient to look on right side, it becomes right beating nystagmus. So direction changing nystagmus. We'll see the example of this central nystagmus. This is central nystagmus. So on looking to the left side, it is left beating, and on looking towards right side, it is right beating nystagmus. Fast phase of the nystagmus is on both sides, and it is not affected by visual fixation. So third thing, then we have examined for nystagmus. If patient now on examination, if doesn't have nystagmus and comes with vertigo, then we should go for Dix-Hallpike test. Most common diagnosis in a patient presenting with vertigo is benign positional vertigo. So everybody should know how to do about head, how to do the head Dix-Hallpike test, and we should do a Dix-Hallpike test in all patients presenting with vertigo. So how it is done? So in Dix-Hallpike test, patient sits on the couch. If you want to test his right posterior semicircular canal, turn the patient's head to the right side. Patient head to right side by 45 degree, and suddenly make him lie down, and head should be hanging down by 20 degree below the head end of the couch. And if patient has posterior semicircular canal BPPV within a duration of 20 to 30 seconds, patient will complain of having vertigo, and you will see the nystagmus. Nystagmus is of vertical torsional nystagmus beating towards the ear, right ear, same ear. And this nystagmus generally disappears within 1 minute in BPPV. So it is diagnostic test for BPPV. If you want to check for left semicircular canal, same procedure we have to repeat on left side. That is turn the head to the left side by 45 degree. Again, make him lie down and observe for the nystagmus. So now test for vestibular hypofunction. Now patient has come with the vertigo, and on examination he has nystagmus, continuous nystagmus, and patient has presented with acute vestibular syndrome. So then we should go for the test for vestibular hypofunction, that is head impulse test. Head impulse test is basically, it tests the integrity of vestibulo-ocular reflex, and it helps to differentiate between vestibular neuritis from stroke. In any patient presenting with acute vertigo of more than 24-hour duration and having nystagmus at rest, it is mandatory to do head impulse test. Head impulse test helps to differentiate between stroke from the vestibular neuritis, which is more benign condition, which doesn't require evaluation, simply treated with steroids. So if patient has positive head impulse test, that indicates the vestibular neuritis. How do we do head impulse test? In normal state, what happens here? In normal state, while doing head impulse test, ask the patient sit in front of the patient, hold the patient head, ask the patient to fix the vision towards patient's examiner's nose, and we have to give sudden jerks to the left and right side. Normally, here the jerk is given, head is turned to the left side. Whenever you turn the head to the left side, eyes move in equal and opposite direction quickly, so as to maintain the visual fixation. Here you can see the when head is turned to the left side, eyes are moved quickly to the right side to maintain the visual fixation. So in pathological state, whenever there is dysfunction of labyrinth, suppose there is dysfunction of the left labyrinth here, when head is turned to the left side, eyes also move along with the head. So patient losing the visual fixation, and then brain realizes that visual fixation is lost, and it will be followed by corrective saccade. Brain tries to correct by bringing eyes to the object. So there will be a corrective saccade. So this corrective saccade can be, you can see on head impulse test. So I will show you the example of head impulse test. This is positive head impulse test, how it is done. So this patient, on looking to the right side, so on turning head to the left side, there is normal. You can see here. So normal on left side, on right side, turning head to the right side, patient has corrective saccade. So patient has positive head impulse test on right side. So patient has left right vestibular neuritis. Another important examination is Hint's examination. Hint examination is important in patient with acute prolonged episode of vertigo. What is Hint examination? Hint S is for head impulse test, then N is for nystagmus, and test for skew. What is the test for skew? We'll see in the subsequent slide. Patient having normal head impulse test and central nystagmus, direction changing nystagmus with positive test for skew. It indicates that stroke in acute vestibular syndrome. It has got sensitivity of 100% and specificity of 96% in identifying stroke in patient with acute prolonged vertigo lasting for more than 24 hours. Even in this patient, MRI can be normal. In 12% of the patient, in this patient, MRI can be normal. So diagnosis is purely clinical and by examinations. Subsequent MRI will show the infarct after 24 hours. So how the test of skew is done? In test for skew is nothing but it is alternate cover test. Here we have to cover the eyes alternately and look for the movement in uncovered eyes. In uncovered eye, which is you see the vertical movements, indicates that there is misalignment of the eyes in vertical axis. So it indicates that there is dysfunction in the brainstem due to infarct or demyelination. Now new dizziness classification has been proposed by Newman and Tucker in 2013. Old classification, which was proposed in 1978, was like this. We have seen that vertigo, pre-syncope, lightheadedness, and dizziness. These terms were very vague, difficult to describe by patient, and difficult to come to the diagnosis based on these symptoms. So for better diagnosis and better workup, this new classification model has been proposed, and this is based on the 4 T's like symptom triads, then triggers for the vertigo, then timing of the vertigo, and targeted approach towards the treatment. So first type is acute vestibular syndrome. That is, acute vestibular syndrome is vertigo lasting for 24 hours, as we have already seen stroke and vestibular neuritis. Second category is triggered episodic vestibular syndrome, where the symptoms last for seconds to minutes, and it is seen in benign positional vertigo and orthostatic hypotension. Third category is spontaneous episodic vestibular syndrome, where the vertigo lasting for seconds to days, but majority of cases vertigo lasts for minutes to hours, and seen in vestibular migraine or Meniere's disease. And chronic vestibular syndrome, where patient has chronic dizziness seen in like post-exposure tumor or medication side effect or vestibulopathy. Now in subsequent slide, I will show you the example of each of these categories clinically. So I am showing you the case of acute vestibular syndrome of peripheral origin. So this is a 45-year-old male patient, truck driver who can't drive, who presented with severe dizziness for last 2 days and nausea vomiting. Whenever he opens the eyes, he feels like everything is moving, and he prefers to lie down lie still with eye closed. There is history of recent upper respiratory tract infection, but there is no history of tinnitus or hearing loss. So this patient has vertigo for more than 24 hours, nausea, vomiting, and he is disabled. So we are dealing with acute vestibular syndrome. Now we have to differentiate whether it is peripheral or central. On examination, neurological examination, he has spontaneous unilateral nystagmus to the right side. His rhombus face is normal, speech is normal, finger nose finger is normal. Gait, he tends to sway slightly on left side, but patient is able to walk. So syndromic diagnosis is spontaneous vestibular syndrome. So here you can see, on looking to the right side, there is no nystagmus. On looking towards left, you can see the left beating nystagmus with fast component to the left side. So he has left. So patient has left nystagmus originating from right. Sorry. So this patient has nystagmus originating from right side, because right labyrinth is hypofunctioning and left labyrinth is hyperfunctioning. Because of that, he has left nystagmus beating towards the left side. And how to confirm that his left right labyrinth is hypofunctioning or dysfunctioning? Here we have to do head impulse test. Here, look at this patient, same patient, head impulse test. On turning head to the left side, the head impulse test is negative. On turning to the right side, he has catch-up saccade, suggesting that patient has right vestibular neuritis. So patient presenting with acutely with dizziness, left beating nystagmus, head impulse positive on right side, has right vestibular neuritis. Then this is another example of acute vestibular syndrome of central origin. This is a 40-year-old male patient, hypertensive since 5 years, presented with intermittent vertigo for last 3 days and imbalance while walking since last 24 hours. He cannot stand or walk without support. There is no diplopia, no dysarthria, no paresthesia. But this patient is disabled. He cannot stand also. Whenever patient comes to the casualty or OPD with vertigo and not able to stand or not able to walk, that means it is a dangerous vertigo. You are dealing with a post-day circulation stroke. Patient with vestibular neuritis, they will be able to walk without support. So examination in this patient showed that on looking towards the left side, there is no nystagmus. On looking towards right side, you can see there is slight right downbeating rotatory nystagmus. And if you look his finger nose test, some impairment on right side, left side looks normal, but if you look his eyes, he has mild ptosis on right side and right finger nose is slightly impaired. And look at his gaze, look at his head. He is not able to stand, he is severely ataxic. He cannot stand without support and severely ataxic. So this patient has right medullary infarct. On examination, we have seen that he has right cerebellar signs, right lateral pulsion, and right torsional nystagmus, right mitosis, and severe gait ataxia. MRI showed diffusion restriction in right side of the medulla. So this is the example of acute vestibular syndrome of central origin. Now coming to the second category, triggered episodic vestibular syndrome. And most common diagnosis is benign positional vertigo, and most common cause of vertigo in our routine practice is benign positional BPPV. So we must know about BPPV. So this is the case, 67-year-old female presented with sensation of room is spinning and it comes and goes. It lasts for only few seconds, brought out only by rolling over, turning in the bed, or looking up to the self. There is no hearing, no hearing loss, no tinnitus, and in between the spell, patient is perfectly all right. So this patient has typical vertigo with change of position, like turning in the bed, getting up from bed or looking up. And in between the attack, patient is perfectly all right, and vertigo lasts for only 2 seconds. So this patient, we should go to Dick sulfide test. Here you can see I'm doing this Dick sulfide test. Head is turned to the right side and patient is made to lie down with head extended 20 degrees below. You can see that patient has symptoms of vertigo. Patient is complaining vertigo and there is rotatory nystagmus beating towards the right side. So this is positive Dick sulfide test suggesting right posterior semicircular canal BPPV. Brief about BPPV. It is due to the otoconia in membranous labyrinth. Normally, otoconia they are present in the ampullary part, and BPPV vertigo is brought down by lying down. If you turning in the bed, or looking up, or getting up from the bed. Diagnosis of BPPV basically, as I have shown you, Dick sulfide test, and most of the patient is posterior semicircular canal BPPV. So diagnosis is by Dick sulfide test, but in horizontal, for diagnosis of horizontal semicircular canal BPP, we have to do supine rollover test. 70 to 80% of the cases of BPPV are due to posterior semicircular canal. Only 10% are due to horizontal semicircular canal. So, what is the treatment for BPPV? Posterior semicircular canal BPPV, Epley's maneuver is the treatment. We should not prescribe the labyrinthine sedatives or drugs for patient with BPPV. We should try to learn Epley's maneuver. It is most effective maneuver for treatment of posterior semicircular canal BPPV. This maneuver you can see on YouTube, or it is available in books. I am not going into details of this Epley's maneuver. Now, third category of syndromic vertigo is episodic vestibular syndrome. There in episodic vestibular syndrome comes the vestibular migraine, TI, and Meniere's disease. This is an example of 50-year-old girl who is missing from school due to disease spells. Patient described as spinning sensation, which is often triggered by the movements, lasting hours, sometimes days, associated with nausea, vomiting, phonophobia, often happens at the time of menstruation. Patient has past medical history of chronic headaches and taking NSAIDs as and when required. Family history of migraine in mother and stroke in the grandmother. On neurological examination, there is no deficit. So this patient has dizziness lasting for hours to days with background history of migraine. Probably we are dealing with a migrainous vertigo or vestibular migraine. This is the criteria for vestibular migraine. I am not going to details of this. During the attack of vestibular migraine, 50% of the patients should have one of these features, like headache with this quality, and other photophobia, phonophobia, and visual aura. So diagnosis of vestibular migraine is by history and examination, and we have to rule out some red flags in this patient. If patient has some vascular risk factors like diabetes, hypertension, we have to rule out stroke in these patients. Coming to the another case, this is a 37-year-old female patient presenting with fullness in the ear, tinnitus, and recurrent episodes of vertigo, vomiting lasting for 3 to 4 hours, which gets resolved spontaneously and recurring again and again. And during the attack, patient has horizontal nystagmus with the left gaze and decreased hearing on left side. Patient has decreased hearing on left side and nystagmus towards the left gaze during the attack, and they are lasting for few hours. There is no headache and recurrent attacks. On neurological examination, patient has just mild ataxia. This patient we have to do for audiometry. If audiometry shows low frequency hearing loss, then probably we are dealing with a Meniere's disease. This is the diagnostic criteria for Meniere's disease. Two or more definitive episodes of vertigo lasting more than 24 minutes or longer, 20 minutes or longer. Documented audiometry hearing loss, low frequency hearing loss at least one occasion, and tinnitus, oral fullness in treated ear. Coming to the fourth category of chronic vestibular syndrome. This chronic vestibular syndrome patient, they come with a history of inability, imbalance while walking, and they have the many times diabetes, underlying disorders, and most common cause is bilateral vestibulopathy, bilateral vestibular failure, which could be age related, it could be drug induced vestibular failure, or autoimmune disease. They can present with bilateral vestibulopathy. And another category is triple PD, persistent postural perceptual dizziness And this dizziness generally happens after the episode of acute vestibular neuritis or some medical illness, some psychiatric illness, where the patient have recovered from the major illness, but after that subsequently they will have continuous dizziness, imbalance while walking, insomnia, and this is a part of psychosomatic stress disorder. So this is a case of bilateral vestibulopathy with giddiness. Elderly gentleman presented with giddiness, imbalance while walking, also complaining of oscillopsia. Oscillopsia means object moving in front of eyes since last 2 to 3 months. Examination, everything was normal. No nystagmus, finger was normal. Speech is normal. Gait appears to be slightly cautious and with small step. So I'm showing you the video of this patient. He says that while turning, he has tendency to lose the balance, and he walks with cautious gait and looking down towards.
काय त्रास होते तुम्हाला साहेब असं काय होते चालताना असं वर झाली करपूर खेळायला फिरताना काय होते चक्र पडल्याने होते ना पडल्याने होते केव्हा होते 2 महिने चालताना केव्हा होते चालताना असं फिरताना होते आणि काही त्रास होते दुसरा काय नाही दुसरा काय उठताना झोपताना असं झोप खाली जाते बरं आणि चालताना फिरताना काय त्रास होतो दिसायला काय त्रास होतो दिसायला काय नाही हल्ले की असं मजबूत माहिती
complaining oscillopsia. His head impulse test is positive on both sides. So look at this video. I'm turning. So this is catch-up saccade. I'm turning to the left. So I'm turning to the right also. He has catch-up saccade. So he has bilateral head impulse test positive, suggesting that bilateral vestibular apparatus. There is dysfunction of bilateral vestibular apparatus and bilateral vestibulopathy. So these are the patients with chronic dizziness with bilateral vestibulopathy. Coming to the medical management of vertigo. Indications for drug therapy. Actually, indication for drug therapy is only for symptomatic treatment. The patient presenting with vestibular neuritis, for symptomatically, for symptom control, we give the labyrinthine sedatives, antiemetics, and there is role of steroids in vestibular labyrinthitis. For recurrent episodic vertigo like vestibular migraine, we give short-term vestibular suppressant like betahistine or cinnarizine. But migraine prophylaxis is the main treatment for prevention of attack. For Meniere's disease, we can use high doses of betahistine and B12 supplements. And for TIAs, we have to treat the risk factor and give antiplatelets. So role of drug therapy is for just symptom control, treat the cause. And for prevention of attack, we have to give the definitive treatment like migraine prophylaxis or antiplatelets or antihypertensives. So we should not prescribe long-term labyrinthine sedatives like betahistine or cinnarizine for long-term because it has got their own side effects. And for BPPV, benign positional vertigo, we should do maneuvers, repositioning maneuvers for the treatment. Treatment of BPPV is repositioning maneuvers, not the labyrinthine sedatives. So medication used for vertigo are betahistine, which comes in the dose of 8 mg, 16 mg, 24 mg. Then meclizine, it is labyrinthine sedatives, which comes in a 25 mg dose. Then diphenhydramine, combination of diphenhydramine 40 mg and cinnarizine 20 mg, which comes with brand name of Stugeron Plus, or other brands are also available. And injection prochlorperazine, that is Stimetil, we can be used in acute vertigo like central origin vertigo or vestibular neuritis. Patient is having severe vomiting and dizziness, that can be used IV during acute episode, now only for acute vestibular neuritis and central vertigo due to stroke, and specific treatment for stroke and steroids for vestibular neuritis. As already told you, treatment of BPPV is repositioning maneuvers. There are various maneuvers: Epley's maneuver, Siemens maneuver for posterior semicircular canal BPPV. For lateral canal BPPV, there are other maneuvers like Gufani maneuvers, barbecue maneuvers. There are various maneuvers. Vestibular suppression we should avoid in BPPV, because if you give vestibular suppression, patient will have recurrent symptoms, patient will be dizzy all the time, and you will not be able to reach the particular diagnosis if you give vestibular suppression in a patient with BPPV. And chronic use of cinnarizine should be avoided for months together, because if you use chronically cinnarizine, it is calcium channel blockers, and it causes Parkinsonism in long-term use. So please avoid use of cinnarizine for months together. And vestibular rehabilitation has got important role in patient with chronic dizziness, especially sequelae of vestibular neuritis patients. This is final slides for approach. The patient comes with a dizziness. First, confirm that whether it is true vertigo or non-vertiginous dizziness like pre-syncope, disequilibrium, or lightheadedness. If it is true vertigo, then look for the red flags like red flags like signs of brainstem stroke. Patient has whether like neurological signs of symptoms, acute deafness, or any new headache or vertical nystagmus. If it is there, then probably you are dealing with a stroke. If there are no red flag signs like brainstem signs, headache, or acute deafness, new onset headache, then probably we have to rule out the other causes like benign positional vertigo. You have to do the Dix-Hallpike test. Dix-Hallpike test, if it is positive, then it is benign positional vertigo. If patient has sustained vertigo with horizontal nystagmus on examination, then you should do head impulse test or head thrust test. And if head thrust test is positive, then it indicates the vestibular neuritis. But now, if patient has other head impulse test is negative and head thrust test is negative and Dix-Hallpike is negative, then you should check for you should ask for the history of migraine causing recurrent headaches. And if patient has unilateral hearing loss, tinnitus, or previous episode of dizziness, probably you are dealing with a Meniere's disease. Thank you very much. So I'm not.
Kadam sir, you are muted, sir. Request you to unmute.
Dr. Kadam sir, please unmute.
Thank you, Babaraj Darku sir, for such a good talk and such a good presentation with all the video explanations and all the direct in the word presentations that has explained all the things about the vertigo, and this all the things were well explained in this lecture. And there are some questions. If there are questions, you can answer. I think question answer box, sir. Please go into it.
There is question when confusion about cause of vertigo, can vestibular suppression steroids should be used? We should not use vestibular suppressions and steroids without confirming diagnosis. It can be dangerous. Second question is, can BPPV last for 60 to 90 minutes, or is it strictly limited under 20 minutes? No. BPPV positional vertigo lasts only for less than 1 minute, not 60 minutes. Vertigo, benign positional vertigo lasts only for 1 minute, less than 1 minute. If it is more than 1 minute, then you are probably dealing with the central cause of vertigo.
One other question. All these questions you can answer live, sir.
Yes, sir.
If they are there. Now I'll like to move this webinar to the next presenter, Dr. Abhay Bhatt, sir, who is sir. Thank you once again from the Nanded IMA for giving us time and giving us a good information regarding this neurological view of vertigo and clearing all the doubts, sir. Thank you, sir.
Thank you for giving opportunity.
Now I want to shift this webinar to the next presenter in our this series, Dr. Abhay Bhatt, sir, who is running a diabetology clinic in Matosri Hospital in Nanded. He is a young chap doing a good work in diabetology and having a good presentations everywhere in the form of webinars and attending many sessions with the general practitioners and clearing their views. Now I invite Dr. Abhay Wak for his presentation.
Thank you so much, sir. Thank you so much for giving an opportunity to talk with such ligands present. They are working in Nanded, and thanks IMA, thanks Johnson and Johnson, and thanks all the supporting team for giving me opportunity to talk on the newer drugs in diabetes management. So I will share my screen.
Yes, sir.
Yes. Yeah. So the newer anti-diabetic drugs. So what is the need of this newer anti-diabetic drug? While traditional drugs which are present in the market, so there are advantages and disadvantages of those drugs which are present in the market. To overcome the disadvantage of these drugs, so there are some newer anti-diabetic drugs which are in the pipeline with many clinical trials in the phase 1, phase 2, and phase 3. So we are giving a brief, not in details, so what are the upcoming drugs and what are the target organs and target receptors for the newer anti-diabetic drugs in near future era, and what are the advantages and disadvantages over the insulins. There are smart insulins which are coming, which are in phase 2 and phase 3 clinical trials. Why there is such a need of these such insulins? So we are going in details with this. So we'll start with this. So diabetes is a global burden, and the diabetes with the global scenario is like in worldwide overall 416 million people they get affected in 2015 with the diabetes, and it goes on increasing into 2040 to approximately 642 million people linked with the diabetes. In that, most of that the Africa, which is most affected with the, up to 93%, followed with Middle East and North Africa, then Southeast Asia, South Central America, and Europe and North America. So what is the Indian scenario? Indian scenario in India, almost there are 67 million people they get affected with the diabetes in 2014, and it goes on increasing. 87 million people they are living with the diabetes in 2030. So this is a burden of a diabetes which is goes on increasing, and because of this there is a need of newer techniques, newer drugs, newer target approach, and because of this there is a need of newer anti-diabetic drugs. So as we know, the multiple pathophysiological multiple complex pathophysiological abnormalities in the type 2 diabetes. As we know, if there is a change in the pathophysiological that leads to hyperglycemia, if there is a decrease in pancreatic insulin secretion that leads to hyperglycemia, if there is increased pancreatic glucagon secretion that leads to hyperglycemia, as well as from the gut, if there is a decrease in incretin effect, and if there is an increased gut carbohydrate delivery and absorption that leads to hyperglycemia. So there are different organs which are involved in the hyperglycemia, like liver, kidney, adipose, and muscles, brain as well as. So depending on the target system, the drugs which are developed, depending on the pathophysiological, if there is a decrease in the pancreatic insulin secretion, the insulins which are developed, there are drugs which are sulfonylureas that increases the insulin secretions that act on the pancreas, glinides. They are also acts on the beta cells of pancreas and increases the insulin secretions. There is a GLP-1 receptor agonist that is having an incretin effect, and DPP-4 inhibitors, which helps to decrease the glucose level in the blood. There are some alpha glucosidase inhibitor, which also helps to decrease the to decrease the carbohydrate absorption and delivery of the glucose from the gut to the blood systemic circulation. So there are some drugs like metformin, which also helps to increase the uptake of glucose from the blood to the peripheral tissue. There are some other drugs like SGLT2 inhibitor, which is a very recent drugs. They are very focused nowadays. Another drugs like dopamine agonist and thiazolidones, which are very commonly used, and that depends on the it all are arrived from the complex pathophysiological abnormalities depending on the patient situation. So what are the common, generally we are using oral anti-diabetic drugs and injectables. So in oral anti-diabetic drugs, there are insulin secretagogues like sulfonylureas. There are categories like grade 1, 2, 3. So glibenclamide, gliclazide, glipizide, glimepiride, these are the drugs which comes under sulfonylureas. Non-sulfonylureas secretagogues like rapaglinide, nataglinide, insulin sensitizers like bigonides, metformin, fenformin, thiazolidones like pioglitazone, rosiglitazones, alpha glucosidase inhibitor, acarbose, voglibose, meglitol, DPP4 inhibitor, sitagliptin, vildagliptin, saxagliptin, linagliptin. There are so many are in the pipeline already, are in use in clinical practice. SGLT2 inhibitors like empagliflozin, canagliflozin, dapagliflozin. Other drugs like pramlintide, bromocriptine, dopamine agonist, and with the insulin, there are different types of insulin like ultra short acting, guanosine, aspart, and lispro. These are the insulin analogs. Short acting insulin like regular human insulin, intermediate NPH, long acting glargine, degludec, detimir, and GLP-1 analogs like exenatide, lexenatide, liraglutide. So these are the drugs which are commonly used nowadays in practice. But to overcome the advantage and disadvantage of these drugs, so there are new injectables and drugs which are coming in the market. There are approval timeline as we go with the history of these drugs when they are developed. In 1996, the acarbose, which is developed like alpha glucosidase inhibitor, then glimepiride, meglitol, lispro insulin in 1996. In 1997, glipizide, glyburide, rapaglinide, which is very good drug for use in an elderly patient with significant reduction in the hypoglycemia. In 1999, pioglitazone, rosiglitazone. In 2000, there is again smart insulin like glargine and aspart. Aspart comes in the market. These are called insulin analogs. Again, in 2001, there is a mixture 3070 aspart insulin. In 2002, so many combinations. And 2005, like GLP-1 analog, exenatide, pramlintide, pioglitazone with metformin combination. In 2006, DPP4 inhibitor, and again goes this list goes on increasing day by day, day by day, day by day. Definitely, we will overcome this problem soon. So there are so many drugs which are in pipeline and already recently developed in 2014, the SGLT2 like dapagliflozin, empagliflozin, and degludec, insulin degludec, Afrezza, that is nasal insulin. In 2015, evogliptin, these are, and U300, these are already developed. So, so there are categories of drugs which are in pipeline, like in phase 1, phase 2, phase 3, and trials. There are some clinical trials also. In phase 3, like ranolazine, GPR40 agonist, and oral insulins. In phase 2, like glucokinase activator, PTP, 1B inhibitor. And in phase 1, there are so many list of drugs which are in pipeline. So, what are the drugs which are in tanks? Like there are glucagon receptor antagonists, DPP4 inhibitors, SGLT2 inhibitors, dual PPAR gammas, then fructose 1,6 biphosphate inhibitor, then GLP-1 receptor analog, intranasal once a monthly, and DAPD drugs. PTP1B inhibitor, glucagon receptor antagonist, and so many. So what are the newer targets for these drugs? So there is a under carboxylated form of osteocalcin seems to have a positive effect on the metabolic syndrome, including improvements of insulin resistance and beta cell function and dyslipidemia. And another like INDYG, it is a deletion mimics. Its deletion mimics aspects of dietary restriction and protects again adiposity and insulin resistance in mice. So there are another targets like VEGF beta blocker, then alpha beta hydrolase dopamine 6 that breaks down the monoacylglycerol and thus negatively controls the insulin release. And inhibition may help the target treating diabetes. And there is FFAR3 beta cell short chain fatty acid receptor. So I'm not going in that detail. So what are the possibilities those who are drugs are in phase 2 and phase 3 clinical trials that soon comes in the market. I'm going to discuss all these things. So there are newer insulin like U300, oral insulin, smart insulin patches, newer DPP4 inhibitor, those who are giving once a week. Nowadays, earlier it was like twice a day we are used to prescribe, then comes at once a day. Now it is like once a week. Then GLP-1 receptor analog. Traditionally, we are having a daily GLP-1 daily dose of GLP-1 receptor analog, and some of them are like nowadays in the market like once a week also. But we are thinking for the once a monthly and yearly. PTP1B inhibitor, the protein tyrosine phosphatase 1B inhibitor, glucokinase activator, dual PPAR agonist, isolate cell transplantation, and artificial pancreas. So glargine U300, it is an insulin which is a long-acting insulin, which is presently in Indian market at a concentration of U100. So there is a threefold more concentrated formulation of glargine, which is already approved in US, and it needs Indian approval. It is in pipeline. So reduced volume, why it is developed? Because it reduced the volume by 1/3 and reduced the surface area by half of the subcutaneous depot. It has a slower and more constant rate of absorption. Insulin glargine 300 provides the sustained glycemic control with the lower risk of hypoglycemia compared with the glargine 100. I'm going to discuss in detail with the PK factor and PD factor of these insulin glargine 100 and glargine 300. As we can see the flattened PK profile, serum insulin glargine concentration, if it is given in the patients, it shows definitely if it is given to patient, there is a one peak of insulin glargine 100, but there is no such a peak of glargine 300, and there is a less chances of hypoglycemia. So this is the overcome over this 100 to 300, and there is a more prolonged pharmacodynamic profile also. If it is with a glucose infusion rate, if insulin glargine and glargine 100, if it is given, we can see this is a peak with the glargine 100, but there is no peak with the glargine 300 if glucose infusion rate. So definitely this gives major advantage to overcome this hypoglycemia with the use of glargine 300. So there are oral insulins which are in phase 2 and phase 3 clinical trials, phase 1, phase 2, phase 3 clinical trials. Some of them are like there are many companies, they are working on this. So there are enteric coated capsule filled with the mixture of insulin and absorption enhancer and the stabilizer. And there are some of the capsule containing with the insulin in dextran and mixture. And there are some tablet also with the Nanded, which are in phase 1 clinical trial for the type 1 and type 2 diabetes mellitus patient for a long-acting insulin analog. As well as there is a Biocon, they are working on insulin modified with a small PEG. And there are so many things which are currently in the market with the newer technology. I'm not going in detail with that. So there is one new technology or new target like dual acting peptide with prolonged GLP-1 activity. So a dual acting peptide with prolonged glucagon like peptide 1 receptor agonist and glucagon receptor antagonist activity for the treatment of type 2 diabetes. As we know, the type 2 diabetes is characterized by the reduced insulin secretion from the pancreas and overproduction of glucose by the liver. So glucagon like peptide, that is GLP-1 analog, promotes the glucose dependent insulin secretion from the pancreas, while glucagon promotes the glucose output from the liver. So taking this advantage of this homology between GLP-1 and glucagon, so GLP-1 and glucagon hybrid peptide, that is a dual acting peptide for diabetes, that is DAPD, was identified with the combined with the GLP-1 receptor agonist and glucagon receptor antagonist activity. To overcome this short plasma half-life, DAPD was PE-glycated, resulting in dramatically prolonged activity in vivo. So these are the newer things which are in the market. So not only we are till date we are just looking for the GLP-1 analog, but along with that we can think about dual acting peptide with prolonged glucagon like activity. So that definitely will help to reduce the burden of diabetes. So what are the different GLP-1 analog? There are so many GLP-1 analog, 2-3 GLP-1 analog which are currently using in the market but we are taking as an injectable form of the GLP-1 analog. To overcome that injectable GLP-1 analog, there are some drugs which are developed by Novo Nordisk like semaglutide, which comes in the oral form as well as injectable. So to overcome that injection, so this GLP-1 analog comes in the market with the oral form. So next is like PTP1B inhibitors. So it is protein tyrosine phosphatase 1B inhibitor. So it acts as a negative regulator for the both insulin and leptin signaling. So inhibition of PTP1B could address both diabetes and obesity. So these traditional therapeutics cannot specify the target of PTP1B. So this is a very specific target. So and antisense based on oligonucleotide inhibit the expression and activity of PTP1B gene without affecting other highly related tyrosine phosphatase. So I'm going to explain in detail with this. So there is a antisense oligonucleotide therapy. If there is a DNA that transcript and it forms a mRNA and then translation to form a disease associated protein. But with this technique, there is from DNA transcription and there is a degrades RNA, there is no translation, and because of there is no translation, there is no disease associated proteins which are produced. So it is a phase 2 program in type 2 diabetes with PTP1B inhibitor that shows the reduction in HbA1c by 0.7%, and there is a reduction in weight by 2.7 kilo. With the advantage with the no hypoglycemia, there is a no change in the renal and hepatic function, and there is a no change in the GI side effect. So next target is like glucokinase activator. So it is like a sensor. These are the activators for the sensor to homeostasis the glucose metabolism. So it is an outstanding glucokinase activator or glucose phosphorylating enzyme. These are the outstanding drug target for the developing anti-diabetic medicines. It has an exceptionally high impact on glucose homeostasis. It is a glucose sensor role in a pancreatic beta cell as a rate controlling enzyme for the hepatic glucose clearance and glycogen synthesis, both the process that are impaired in the type 1, type 2 diabetes. So from these rate controlling enzymes, and because of this, it sends the increase, that is hyperglycemia, and it acts like increasing the hepatic glucose clearance and glycogen synthesis. So and it leads to euglycemic state. So there are next class is also like dual PPAR alpha and gamma agonist. These are the target receptors which are that PPR alpha, which is present in the liver as well as on heart and vessels, and this PPR gamma, which is present in the skeletal muscle as well as in heart and adipocytes. So how they helps this PPR alpha, that increases the free fatty oxidation, that decreases the triglyceride synthesis, that decreases, and because of this there is a decrease in circulating triglyceride and fatty acid that leads to decrease in the free fatty acid release and increase free fatty acid uptake and storage. That leads to decrease in the hyperglycemia, decrease in the dyslipidemia, decrease in the atherosclerosis. And this PPR alpha, which are present in the skeletal muscle, that decreases the fatty acid uptake and storage, and increases the insulin sensitivity and increases the glucose utilization. There are so many patients which commonly we can see in the OPD with the insulin resistance. Already there is a there are patients, though there is a good insulin release pattern, but because of this insulin resistance, so these are the drugs which are in pipeline to reduce the insulin sensitivity. And what are there are some drawbacks which we have to overcome with this PPR, like side effects, like there is a fluid retention, there is a weight gain, and there is a bone fracture, and maybe there is a bladder cancer. So we are overcoming, we are facing, these are the problems to overcome in near future. So next, like it is a isolate cell transplantation. Next part is like isolate cell transplantation, which is which is also in which is also in clinical trials. There are two types of pancreatic isolate transplantation are there. There is one auto transplantation and allo transplantation. In pancreatic isolate auto transplantation, which is performed following total pancreatectomy, patient with the type 1 diabetes cannot receive pancreatic isolate auto transplantation, because in type 1 diabetes, the beta cells which are not survived, and because of that there is a patient comes into type 1 diabetes, and because of that there is no auto transplantation can be done in type 1 diabetes. The surgeon first removes the pancreas and then extract and purifies the isolates from the pancreas, and within an hour the isolates are infused through the catheter into the patient's liver. The goal is to give the body healthy isolates to make the insulin. And with the pancreatic isolate allo transplantation, it is an isolate from the pancreas of the deceased organ donor are purified, processed, and transferred into another person. Currently, this is an experimental, not approved for the therapeutic purpose. And this transplant patient typically receives 2 infusions with an average of 4 lakh and 5 lakh isolates per infusion. In most cases, islet cells from the several different donors are needed. The isolates are infused into the portal vein, and pancreatic allotransplantation is performed in type 1 diabetes, because already we are taking these beta cells from the deceased organ. The isolate transplantation is an efficient treatment for the type 1 diabetes. These beta cells are removed from the donor pancreas and transferred into the persons with the diabetes. As with all organ and tissue transplant, rejection of the donor cells is the greatest challenge. Patients who have to be immunosuppressant, we have to prescribe immunosuppressant along with after this isolate cell transplantation. So immunotherapy is much more costlier than anti-diabetic drug treatment, and it will be more better if patient taking these anti-diabetic instead of taking any immunosuppressants for the lifelong, which may be increase the chances of infection and some cancers. So these are the problems, and these are the challenges which are coming to such a so this is a pictorial diagram that shows pancreas and isolates in pancreas that are collected and isolated and given in the recipient with the type 1 diabetes in the portal vein with the isolate in the portal vein. So there is a recent data of 5-year post-transplant follow-up patients. It prevents the severe hypoglycemia in nearly 90% of the recipient at the 5 years. There is a HbA1c level where less than 7% in 84% of patients at the 12 months, and 70% of patients at 48 months, and 59% of patients at the 60 months after the isolate transplantation. Yeah, definitely. Along with this islet transplantation, patient definitely needs to change his or her lifestyle modification with diet and exercise. These are also important factors after doing this transplantation. So next is like artificial pancreas. So artificial or bionic pancreas. These are the pancreas. These are mimic like a naturally acting pancreas with the dual chambered, two separate pumps for delivering both the insulin and glucagon. It has a continuous glucose monitor, that is CGM, and a continuous algorithm built into iPhone app. So it is a bihormonal bionic pancreas, continues to perform well in the clinical trials. So how it works? So there are glucose sensor which are put on the hand that sense the glucose level in the blood, and there is a controlling system that controls the release of insulin and glucagon according to the blood glucose level, which is administered subcutaneously. So there is a insulin pump, and this is a glucagon pump. So they act while controlling system. This is a controlling system with this is a CGMS, that is continuous glucose monitoring system. So so as we know, in earlier 1930, the insulin which are developed by Banting and Best, which are separated from his dog, and after that in 1922, and it takes almost 1960 to comes in the market. So these insulin and syringes after that for the delivery system, earlier insulin and syringes which are used nowadays also we are using, but in 1979 pumps are comes in the market. In 1983 pens which are in trials, the pens which were using, then open loop and closed loop system which are using. And for the monitoring system, earlier we are checking at a clinic only, and then home monitors like glucometers and these are comes in the market. And now it is like a continuous glucose monitors which comes that monitors the blood sugar level 24/7 for the 14 days. That gives exactly when the patient goes into hypoglycemia, hyperglycemia, what is the blood sugar level and how to manage that blood sugar level. That gives a clear picture after using this CGM. So smart insulin, there are smart insulin. Why there is a need to come to this smart insulin in market instead of taking instead of already we are having a traditional insulin as well as insulin analogs which comes in the market. But smart insulin is what is the definition? Is like definition is as defined as a pharmaceutical preparation which contain an inbuilt sensor mechanism to assess the ambient glycemia and ensure release of insulin based upon this information. It avoids both hypoglycemia dip and hyperglycemia peak while ensuring euglycemia. So these are the smart insulins. There is no need of taking by vial syringe, and there is no need to check from the glucometer. So they already these are the smart insulin. They sense the glucose and they release the insulin from that patch. So as long back as 1979, Brownlee and Cramy reported that the synthesis of stable biologically active glycosylated insulin-derived derivative combined with the lectin called concavalin A. The synthesis ligand-bound insulin releases active insulin in the quantity proportional to the amount of glucose present. This approach, through currently far from perfection, has the potential or revolutionized insulin therapy. So these conventional insulin, these are the protein binding ligands, bulk hydrogel matrix and phenyl boronic acid. So these are the conventional preparation. But in smart insulin, there is a nanotechnology based smart insulin like nanomembranes, macrogels and nano networks. So these are the patches. As we can see, these are the patches and these are the sensor. So they sense the glucose, and there is a glucose if there is a hyperglycemia, there is a glucose oxidation and there is a release of insulin. So there is no need to monitor blood glucose. So these sense and they release insulin and make the patient euglycemic. So what are the basic principle for the smart insulin? So every smart insulin has two components like a glucose sensor and insulin delivery devices. And in recently developed nano network, exposure to hyperglycemia leads to enzymatic catalysis of insulin nanoparticles and allows to release of insulin. The duration of action of these nano networks is 10 days in type 1 mice and has been noted to up to 14 days in some animal subjects. So again, there are pros and cons with the smart insulin. So this field seems to be promising era for innovation, and patients have been drawn for the glucose responsive insulin formulation, including microgels, amphilic hydrogels, and thermosensitive polymers. Insulin secretion follows the non-linear pattern, so it is not definitive. It is not definitive. The patient can goes into hypoglycemia or hyperglycemia also. So and any inorganic or non-living insulin secretory apparatus would not be able to replicate the work of organic live isolate of Langerhans. Definitely, this is the challenge we have to overcome with the technology to improve these pros and cons. Thank you so much. Thank you so much for giving opportunity, Johnson and Johnson, the supported team. And I especially thank Dr. Suresh Kadam sir for giving me opportunity to talk on newer insulin. I thanks all my colleagues, my seniors and my juniors. Thank you so much.
Thank you, Avera. A good informative talk on the newer insulin and our views about the treatment of diabetes, changing our views. It was a very good informative lecture done by you. A good presentation. All the slides were very good and they were explanatory slides. And I thank you from IMA Nanded for giving us a time for this lecture.
Thank you so much, sir. Thank you so much, sir.
Thanks. Thank you all the team of Johnson and Johnson for providing us the opportunity and giving us a time. I again thank the team DigiShield from Mumbai who are effortlessly working from last 7 days for this event to be smoothly going. All the things were very smooth and no interruption in between. All the lecture were very informative and it has given a good message of information in this time on online webinar was a successful thing. And I again thank you to all the participants who are the main backbone of this, who have remained attendee since there is a 240 attendance from start to end that was there, because there was the same time there is a webinar in Latur. We have got some lesser number of, or otherwise 500 more we are expecting. Next time we'll inquire and keep our this webinar. It will not match every organization will be asked. And I thank and I conclude this webinar with this. Jai IMA. You can leave the webinar. Now the webinar has been completed.